So good morning, everyone. I'd like to welcome you to what is now our second Alcohol and Drug Abuse Institute Symposium on Marijuana. I'm Dennis Donovan. I'm the director of the Alcohol and Drug Abuse Institute, as well as a professor in the Department of Psychiatry and Behavioral Sciences, and I welcome you here today. Before I give you substantive introductory comments, I want to talk about the more important things, and that's where the bathrooms are. As most of you probably were aware, the bathrooms are directly across the hall, and if in fact they're full, there's a stairway that goes down to the floor below us, and in the same place, sort of logistically, there's another set of bathrooms. While we will have lots of food for thought throughout the day. Yes? I'm not aware. I'm not familiar with the logistics of the building here with that in mind, so I don't know. As far as food for thought, we'll do that throughout the course of the day, but around lunchtime, we actually have substantive food. There's a cafeteria. There will be boxed lunches. On the back of the program, you can see the options that are available to you, some of which are vegan, some of which are gluten-free. So you can take a look and see what's there. To let you know that we will be recording the speakers in the sessions, and recordings as well as slides, as well as biographical sketches for the speakers will be found subsequently on our web page at the Alcohol and Drug Abuse Institute, and there are links, again, where you can see those links on the program. So hopefully that will kind of get you through the important pieces, right? So the substantive part. We sponsored a symposium on the legal use of marijuana in Washington State in November of 2013. And it was titled Shaping a Research Agenda. Well, it's now May of 2016. And lots of things have happened in that intervening time frame. So what we would hope to do today is have the opportunity to sort of bring all of us up to date on some of the changes that have taken place. On the one hand, we see that policies continue to evolve through the course of those last couple of years, both within the state, across the country, within tribal communities as well. So part of what we will do in the course of the day is to learn more about those different policies, how they've changed across time, and what implications they may have for the state, both with respect to policy development and implementation on the one hand, but also for research opportunities and direction. Secondly, we here at the university have been given the opportunity through I-502 funds to conduct research and disseminate research information dealing with alcohol from the Liquor Control Board before it became the Liquor and Cannabis Board. And now we have funds that will facilitate that same research and dissemination around marijuana. Today is being sponsored in part by I-502 funds, so we appreciate that opportunity. But today you also hear about some of the activities that have been ongoing in the development of research and the implementation of research and results from some of that research that's been funded through the auspices of I-502 funds. In the course of your going to lunch, getting your boxed lunches, you will see also in the cafeteria a series of posters that talk about some of the work that we within the Alcohol and Drug Abuse Institute have been doing with those funds, so you can get an idea of some of that. But I also want to acknowledge that there are many other researchers here on campus who are actively involved in research opportunities around both prevention, policy, and treatment. So you'll hear some of that today as well. So with that, I would like to, first of all, again, welcome you and then introduce our plenary keynote speaker. We had the opportunity to bring to Seattle from Southern California, where she says traffic is even probably worse than ours, Rosalie Pakula, and I will read to you because it's an impressive list. And she will probably say, well, you've just taken my 45 minutes in the introduction. So let me just read this to you. Rosalie Pakula is Senior Economist at the RAND Corporation, Director of RAND's Bing Center for Health Economics, and co-director of RAND's Drug Policy Research Center. I think that qualifies her for being here. Her research over the last 20 years has largely focused on issues related to the markets for both legal and illicit substances, examining policies that impact both the supply and demand with a special focus on alcohol, tobacco, marijuana, and prescription opioids, substances that we're well familiar with here. She has studied and evaluated marijuana policy here in the United States and abroad for over a decade, writing a book published by Cambridge University Press in 2003 entitled Cannabis Use and Dependence, Public Health and Public Policy. And she's been a writer of many peer-reviewed journal articles on the impacts of marijuana decriminalization, medicalization, and legalization policies. So with that, I would like to introduce Rosalie Pakula.
Well, thank you very much, Dennis, and I really appreciate the opportunity to be here. This is an exciting place to be when you're going to talk about marijuana policy. It's exciting because Washington State has really taken a very unique approach that's different than even from the other states that have developed medical and recreational marijuana policies. So there's been a lot of anxiety around the changes in policy, particularly the change to legalization that's been occurring in the states and not just in U.S. states. This is the DEA Administrator, Michelle Leonhardt, arriving in the emergency room saying, marijuana legalization is killing me, and the doc saying, nah, don't worry about it, it's just a panic attack. Again, of course, that marijuana itself is not that deadly a substance, or at least has not been understood to be a deadly substance, and so what is all the hype and concern about? We've been liberalizing policies for nearly 3 decades now, and so there is a lot of relevant appreciation for the fact that, this isn't an enormous step given some of the changes that have occurred. So what I would like to do today is walk you through what has been happening in terms of marijuana policy over the last few decades, provide you with some very clear definitions about what is this change, legalization, what does it really mean vis-a-vis what's been happening in the past 3 decades. How is Washington State's laws unique and different from what's happening in other states that are also experimenting with policies? I want to also then cover why previous evaluations of the impacts of these former liberalization policies might not be very informative for understanding the implications of legalization today, and then what it is we need to be concerned about from a public health perspective. And I want to be clear that I'm providing information on a public health perspective not because I think that's the only perspective that needs to be taken. It isn't. It's a relevant one, though. And it's a relevant one that didn't engage in the early legal changes because the public health perspective initially was just say no. I think we've moved beyond that. And if we're going to move beyond that, we need to think about what those priorities are and what sort of aspects of a policy are desirable to make sure that the changes that occur are mindful of public health concerns. So let's start with a primer on marijuana policy. And as I've said, basically marijuana policy reform, I said 3 decades, yeeks, it's actually 4 decades now, have been changing in the US considerably with marijuana decriminalization back in the 1970s, currently recognized medical marijuana policies adopted in the mid-1990s, and I say currently recognized because there are actually states that rescheduled marijuana in their state-controlled substance schedules back in the 1970s. And then marijuana legalization policies that are, of course, of great concern. This is really a spectrum of policies. This is not dichotomous changes. We don't go from a world of absolute prohibition to a world of legalization without some moderate steps in between. And understanding what these definitions are is really important for when you're looking at the scientific evidence of the impact of these policies, or when you're deciding to evaluate them. Let's start with prohibition. Prohibition can be very tough sanctions against any aspect of the market, whether it's supply or demand, possession, use, distribution, any of it. They could be very, very stiff penalties, or they could be mild and moderate, and it could still be a prohibition. The approach depends on the jurisdiction. Decriminalization goes a step further. In prohibition, it's still criminal to use, possess, cultivate, sell. In a decriminalized policy, usually decriminalization means removal of the criminal status of use and possession of typically small amounts of marijuana. So decriminalization is a movement to in some cases, reduce the harm imposed on users. Usually we don't have decriminalization of sale, although there are, in some cases, and I would point to the Netherlands as one of those cases, policies of non-enforcement. On the books in the Netherlands, it is illegal to sell marijuana in any shape, way, or form. Wholesale production and cultivation of marijuana is actively enforced against, and people are thrown in jail in the Netherlands for growing and distributing large quantities of marijuana. They have a policy of non-enforcement with their retail coffee shops. They agree it's okay to look away because users shouldn't be punished. And in fact, the store owners, as long as they follow a strict set of rules, will not be punished either. So it's okay for it to go out the front door. It's how does the marijuana get in the back door? And that prohibition on the wholesale production and cultivation of marijuana is what has kept prices in the Netherlands very high, consistent with illegal markets, which is why studies that did evaluations of San Francisco and the Netherlands said, well, look, they've basically legalized, and in San Francisco it's prohibited, and prices are pretty much the same. Well, guess what? These weren't comparable environments. The thing that was comparable is both prohibited large-scale wholesale production and distribution. Think of tobacco where you don't have a tobacco company, guys. It's a very different market. So lots of studies have been done examining the state variation in decriminalization policies, but unfortunately, even these studies haven't led to consistent conclusions necessarily on the effects of removing the criminal status related to possession of small amounts of marijuana. And the reason why is that these are not homogeneous policies, unfortunately. Many of the states, Alaska, Colorado, California, my home state, retained the criminal status associated with possession. They reduced the jail time to 0. You didn't have to go to jail, but it was still a criminal offense. So what does that mean? Anybody on probation and parole who is caught in possession of marijuana can get thrown in jail because it's not going to be decriminalized for them because it's a criminal offense, it's a violation. So you can still have arrests rising in decriminalized states if the criminal status is maintained. In other states, it only applied to first-time offenders. Didn't apply consistently across the board. So a state that allows first-time people to get away with it looks different than a state that allows anybody, third, fourth, fifth-time possession, to not be thrown in jail. The strict limits on amounts, some states have strictly less than an ounce, other ones have a lot more than that, makes for a very different look of the market. And then finally, because of these variation in these definitions, when you try to do an analysis of the impact of the decriminalized states, there were 11 of them that got recognized as decriminalized in the late 1970s and early 1980s. When you look on the laws on the books, many states had things called conditional discharges for first-time offenders. So a state that didn't decriminalize but had a conditional discharge for first-time offenders looks just like a state that did decriminalize but only allowed it for first-time offenders. So it's not surprising that these studies were inconclusive in the study of the effects because you weren't looking at a treated group that was homogeneous against a control group that was different. The science didn't support it. Then we have the move to medical marijuana policies. Medical marijuana policies basically speak to the criminal sanctions associated with patients and subsequently, as they evolved, suppliers for marijuana in this small market restricted for medical purposes. The restrictions on growing and selling of the supply is something that evolved with medical marijuana laws. California's first policy did not allow for people to have dispensaries. There were dispensaries in California then, but it was not legally protected until 2003. That gray area meant that you had cities like San Francisco, Santa Cruz, some others, experimenting and pushing the legal limit of the law, and other cities like San Diego, San Bernardino, Riverside, fiercely not allowing it. How do you evaluate the impact of a law in a state when you don't have a state with a comprehensive single policy? It's difficult. While there, as of December, and this is a constantly changing number, we were laughing at a recent conference, everybody's got to have their map of the medical marijuana states. December 2015, there were 24 recognized states, plus the District of Columbia, that had what are widely recognized as medical marijuana laws, those that are frequently recognized by the media. But in essence, there are actually significantly more states that have adopted policies that recognize the therapeutic value of marijuana. They've done so in a much more narrow way. They only allow high CBD marijuana to be sold and in certain types of products. Sometimes the supply chain is not well specified. Gee, that looked a lot like California when we first passed our law, so that's not terribly surprising, but a lot of the advocacy groups say, well, then that's not really marijuana because the patients can't get it. They're beginning to figure it out. So if you want to know where the states lie in terms of their willingness to accept that marijuana should be treated as a medicine, I think this map speaks for itself. But if you're doing an evaluation of the impact of medical marijuana laws on, say, norms, and you ignore the yellow states, you're actually not doing a good job of capturing the states that have legally decided that this is a medicine. They just might not have the same scale of market allowed. Then there's legalization. And legalization, from a policy analyst standpoint, means the explicit recognition and allowance, removal of criminal sanctions for the cultivation, processing, distribution, delivery, and retail sale of marijuana. Now, I just listed a whole bunch of things. Actually, you don't need to legalize all of those to have a legal market. But in essence, as it's been defined by the states that have been experiencing the policy, in essence, they're basically providing legal protection, allowing the market to exist, removing the criminal sanctions. In a report that me and my colleagues at RAND did for the state of Vermont that was going through the state legislature, they wanted to propose a bill to legalize marijuana. They wanted to know what their options were. And what we showed them, one of the biggest insights that the legislature thought we provided, was an idea that there is more than two different versions of marijuana policy. On the top, there's the strict prohibition, and you can increase sanctions, or at the other side of the top, you can still have a prohibition and reduce the sanctions. If the criminal justice costs of prohibition are getting too big, decriminalization, true decriminalization, not just of first-time offenders, not just of small amounts, does a great deal to reduce the criminal justice costs associated with marijuana policy, and it does so without moving to legalization. That doesn't mean that's the right policy. It just means that that is an option that could be on the table. If you go to sanctioning a legal market, allowing a legal market, we offered 10 different alternatives to what you could have in terms of a prohibition, one of which looks just like the Dutch model, which is allow for retail sales, don't allow for lots of licensing of cultivation and processing. Keep that really tightly regulated, say one grower, maybe it's the government that grows and distributes the sale. Is that the ideal policy? It depends on the jurisdiction. It depends on the jurisdiction's goals. But right now, when we talk about legalization, to most places that have been considering it, they go straight to the standard commercial model. Let's do it like alcohol. Maybe that's ideal, maybe it's not. And if you're going to talk about what's right for a given jurisdiction, in order to have this discussion, let's start with the jurisdiction's priorities and what aspects of the policies meet those priorities. Legalization is more than just about what type of market are we going to allow. Are we going to allow commercial sale by for-profit industries? Are we going to allow for-benefit companies to be the ones? So profit is not the only thing that's motivating the production. They have to have some other public goal. in a for-benefit company. That's a legal market too. It's just not profit-driven. But that's one aspect of legalization. There's a whole range of other policies that, gratefully, Washington State has paid significant attention to, but other states have not, in terms of regulation of the products that can be sold. When you talk about the products, we know there's the plant itself, there's significant variety, but then you have all the derivatives from the plants that can go into the oils, they can go into the solids, they can go into the edibles. What sort of products do you want to allow in the market? Do we need that much diversity in order to improve personal freedom or allow people to have access? Do we want to allow any potency, or do we want to regulate potency? None of the policies thus far have talked about regulating potencies, although some of them are now talking about testing the potencies of the different products being done. Regulation of sellers and servers. To some extent, there's some rules of that in the retail sales, but we have lots of rules around that in the case of alcohol for anybody who's studied alcohol policy. In fact, if I give alcohol to a minor in my own home, I can get severely punished. Regulations on marketing, and by this I mean not just whether or not there's allow for signs, but it's advertising and promotion. And again, this is an area where Washington State has done a lot of heavy thinking, and yet other states, like my own, tend to say, well, we're going to do it like alcohol. Alcohol wasn't an explicit policy, folks. It's a policy that's been evolving over some time, and for a long time, it was a self-imposed policy, the liquor industry deciding not to advertise. That was not a legal restriction. Regulations on use. This is where we give a little bit more thought about these policies as we've been adopting them. Who can use, where can they use, with what? Can they only consume on the stores where they're getting on-premise consumption, or can they only consume in the privacy of their own home? These sort of aspects are being considered in the laws a little bit more thoughtfully. And then, of course, taxation, which is where we get the revenue. How is Washington recreational system different? Well, it's not different in that it is a commercial model. It's for-profit companies that are allowed to open cultivation, distribution, and retail companies. They're limited in the number, and the number has actually gone up now that they're trying to pull in, I understand, with the get the medical market more integrated with the legal market. The number of licensings for retail outlets is growing. And the tax level is high compared to other states that have adopted these policies. Retail stores are being restricted only to sell marijuana and marijuana paraphernalia or products. That's fine. That's also consistent with Colorado, and it's being considered for Oregon and Washington as well, or I'm sorry, Alaska and Oregon. It does not allow home cultivation. This is unique. Washington is very unique in not allowing home cultivation for recreational purposes. And actually, that's quite brilliant. The ability to keep an illicit market out is dependent on your ability to have knowledge of the legal market. The sale-to-seed tracking system and the exclusion of home cultivation allow Washington State to know what is being produced in the legal market and where it's coming from. So it's much easier for police and other authorities to determine what wasn't produced through that system. The idea of no personal use, no personal clubs, this is actually what Uruguay is doing. Uruguay is allowing for the sale in pharmacies, a very restricted area of retail, and personal consumption clubs that you have become a member of. That's different. That's a very different model than what we've done in Colorado or Washington or being proposed in Alaska or Oregon. Washington was really groundbreaking in their approach to edibles. It wasn't any edible product on the market. They saw what happened in Colorado and the risks that occurred with naive users and some children getting their hands on edibles, and they were smart. They put rules around the process for creating edibles so that when you take a bite of a cookie, it has about the same THC in that one bite, in the first bite, as it does in the last. That is necessary in producing edibles if you want to maintain the safety of it. Because without the sort of homogenizing process that is required in the state of Washington, it's entirely possible for an edible product to have varying potency across the product. And a naive or even a somewhat regular consumer can get a high dose of potency in a small amount of time. And that could have public health implications. The other thing that's unique about Washington State is it retains its criminal penalties for possession amounts above the legal thresholds, as well as cultivation amounts above the legal thresholds. You guys have not allowed full-scale legalization. This is a careful, moderate step. You're controlling the size of the market by saying that you won't allow things above certain thresholds. What does that mean? It means the Washington experience will be different from, say, Colorado or California. So what's the implication of these definitions? The real important thing I want you to take away is that a lot of research, like I said, has been done on decriminalization policy, on medicalization policy, and yet you can see by this picture, the treated groups and the untreated groups are really hard to identify. Our very good statistical methods, our standard approach, different estimation, doesn't do it if you're not mindful of the fact that some of your control states look just like your treated states. And that is important for understanding the science that has emerged thus far. My key point about why policies haven't told us much, it boils down to that heterogeneity I just showed you. But it's not just decriminalization. Medical marijuana laws in those 24 states in DC look very, very different. You have different rules on the patients that can have access in terms of what conditions they're allowed to have access for. Early laws were a bit liberal in terms of what conditions. The medicine is evolving. You have some recent states like New York and Massachusetts that are much more restrictive. And then the CBD states, the high CBD states, are even more restrictive, saying it's only for seizures or MS. That's important because that determines the size of the market, the number of patients that can gain access, and the likely impact it could have in terms of overflow on a recreational market. Even states that differ in terms of dispensaries, Washington State, when it first passed its policy, did not allow for dispensaries, and still legally there were no, quote, dispensaries allowed until 2011. There were cooperatives allowed, right? That's very different than California, which in 2003 said, we'll call them cooperatives, we can call them dispensaries. You don't have to have a one-to-one relationship. As long as you go in and sign a piece of paper and say, this is my dispensary, we have a relationship. You're my caregiver. That's a very different approach. It's a more commercialized approach, allows for broader access. And so if you're going to do a comparison of Washington's medical marijuana law to California's medical marijuana, our medical marijuana system looks a lot more like your legalization system than it did like your medical marijuana system. And if you're evaluating the impacts of the policies, you need to be mindful of that. Also, current research is also ignoring how the laws have changed over time. These aren't single steps. These aren't things that are stagnant. California, if you want to evaluate the impact of medical marijuana in California, I keep harping on this as an example because it's one that has been studied widely in the literature. Our first policy in 1996 was very, very vague, and many jurisdictions within the state did not allow for dispensaries. They knew that patients could grow, but they started imposing their own restrictions on how much. Dispensaries were allowed in 2003. They existed before then, but if you're going to evaluate the impacts of California's medical marijuana laws on, say, kids' perceptions of harm, should you be studying the 1996 policy or should you be studying the 2003 policy? That depends. Depends on what your expectations are in terms of the impact of a vote and teens' awareness of the vote and the commercialization around a vote, or their exposure to storefronts and the impact of that on their changing perceptions, or the impact of somebody they know smoking it for medicinal purposes. If they're growing in their own home, their perception is different, their understanding is different than somebody who's not. And in a state like California, that was determined at the local level. So understanding that is really important. Even with legalization, And there are going to be numerous studies coming out very soon. I keep reviewing them for peer journals, evaluating the impacts of legalization here in Washington and Colorado, looking at the change of the law in 2012. You guys sitting here know your policy in 2012 was just the first step, and it has changed, and it continues to change. And a key aspect of your policy was that stores didn't open until July of 2014. So if you're going to evaluate the impact of the legalization in a law that wasn't really, you had a state that previously didn't allow for home cultivation except for medical purposes. Your legalization policy does not allow home cultivation. How are people going to get recreational marijuana in a state that legally didn't allow home cultivation and didn't have stores open until July of 2014? Yeah, there were workarounds. There were some people who gained access, and people were not thrown in jail for possession. That's great. But the impact of legalization in terms of the market and the availability in the market can't be studied until the market starts to exist. This is true even when we look at the medical marijuana laws. One of the things that I'm showing here is the bars are the number of states that have passed medical marijuana laws. The dots are the number of patients that registered in the states that had laws. Patient registries have been used as a way of measuring the size of the medical marijuana market in a given state. Now, not all states require patient registries. Because of the federal prohibition, there's true legal risk in a patient putting their name saying, I am a registered user, even if it is for medicinal purposes, because the federal government doesn't recognize that. But with the Ogden memo in 2009, where the Department of Justice said, okay, we're going to let states experiment as long as they are enforcing the rules of the state, we will let the states experiment. And all of a sudden, the next several states that adopted policies had the mandatory registration. Why is that helpful? It's helpful for a variety of reasons. Law enforcement has a really difficult time differentiating the black market from the legal medical market if they have no way of verifying that your medical marijuana card is indeed legitimate. It's really difficult to separate those markets then. So the lack of attention to some of these details is what's really been causing the tremendous uncertainty in the literature. You can find studies that show big effects of medical marijuana or no effect of medical marijuana. And it really depends on your orientations, which ones you're going to emphasize when you give a talk. What I'm showing here is just that point that, and this is just a few studies that have been used and widely cited, including my own, that look at the impact of the medical marijuana laws on adult prevalence of marijuana. And again, prevalence just being, use in the past 30 days or any use in the past year, depending on the study. And depending on the years in which the study was being evaluated, how they treated the law, when the state first passed their first law, or they actually paid attention to the changes in the dimensions of the law, and when the market evolved, and how many patients were provided access, and whether there was home cultivation. Studies that were more cautious, you can still get varied responses because the impact of the policy itself, the state changes, continue to evolve. I think the best example is the marijuana treatment admissions analyses. Data from all 50 states, the exact same data set. Just looking at different states, a different time period in which the studies were being evaluated. Our study went all the way back to California. California's policies, Choose did not. And you can get a different effect of the policy. So what happens if we focus more on the dimensions of these policies that we think should influence adult recreational access, such as presence of dispensaries? There you start to see a bit more consistency. You'll still see some variation depending on the years of data, the years of state policies that are evaluated. And why is that? Why is it there's 3 that are positive and 2 that say not significant? And the reason why is this. Marijuana dispensary policy continues to change. I was somebody who was saying early on, oh, it's the dispensaries, it's the legal protection of dispensaries that are operating, that are allowing for a market and the commercialization of medical marijuana. That's not the case with recent state statutes that are very restrictive in the number of dispensaries that are being allowed. And when we get more states that are passing these policies, and they're tighter policies, then the effect of this dispensary is less because there's less commercialization going on in Massachusetts and New York medical marijuana dispensaries than there were in California and Colorado's. The data is changing. So the other reason why we have to be careful interpreting evidence from early studies is that they have focused, by and large, on simple measures of prevalence. Do we really care if somebody has any marijuana in the past year from a public health perspective? If the philosophy is not just say no, do we care about any use? Or do we care about something that would look similar to a binge drinking episode? How do we define that? What is that? We don't know. We don't know. We have proxies, near daily use. Okay, let's go back to alcohol. A near daily drinker could be drinking 1 glass of wine a day and have 0 harmful effects, and in fact, very good healthy effects associated with drinking. Whereas somebody who drinks a lot of alcohol every day is having a very different impact on their body and is more likely to get behind a wheel and drive drunk than the person who's only had 1 glass of wine a day. We need better measures to capture use. And what we haven't been paying attention to in our studies of these liberalization policies, starting with medical marijuana and moving into legalization, is the fact that heavy users, while there's been very little change in prevalence until real recently, 2009, it started to rise. The prevalence of heavy use, defined as use on 20 or more use occasions or days in the past month. Okay, that's still not a definition I really like, but it's closer to somebody who's using regularly. That's rising. And when we did an estimate for the Office of National Drug Control Policy on the size of the market, what we found out was the number of use days among people who are using 20 or more times in the past month, the amount that they report consuming, has grown significantly in the past decade, as opposed to casual users. So we need to be careful thinking about measures of prevalence, because that's not the right measure. If you track heavy use, we need to develop a better measure of heavy use. But let's just say we look at treatment episodes. Treatment admissions for marijuana have been rising over this time period, even if we look at the non-criminal justice referrals, because lots of states, it's against the law to be using marijuana. Youth get diverted to treatment instead of to jail. So you have a rise in treatment episodes just caused by the criminal justice system, not because of really problematic use. When you take those out, you still see that there's been a definite incline in the number of treatment episodes for marijuana in the United States with the medical marijuana policies. What's interesting, guys, this is the exact same thing that's happening in the Netherlands. I could show you a slide. I didn't actually put it in there, so don't worry, you're not missing it. Treatment admissions have been on the rise for marijuana in the Netherlands, too. So we need to be thinking about what measures of use do we need to be monitoring in our data systems to understand the impacts of the policies if we care about the actual implications of the policies. And then finally, we need to be thinking about what sort of products are being used and the methods of consumption. All of this is talking about use of any marijuana. You guys know from reading your own newspapers, dabbing is a very dangerous and scary thing. It gets misused. It's not any marijuana. It's a high-risk form of using marijuana. Doesn't mean everybody who dabs is going to have a problem, but the chances of a naive user having a problem are much, much higher. Edibles are risky if they aren't scored, as they are now. If they're scored, that helps, but we can't make sure a 10-year-old doesn't know they're only supposed to eat a quarter of a cookie, right? So there's things that we need to be thinking about in terms of the types of products that get consumed when we see a negative event. Are there products that are more associated with the negative event? Or is it just marijuana in general? I think that marijuana in general is a crazy idea. If anybody had this discussion about alcohol, you'd have the wine industry saying, what the heck? There's different products, and we need to be thinking about that in our policies for marijuana. So the third point was just basically what sort of important elements should we care about if we're going to look at policy from a public health perspective. And in this case, it's really important to start with what are the public health priorities. If it's not just say no, and I hate to tell people this, but we really need to move beyond just say no because we've gone past just say no already. What sort of priorities should we have from a public health perspective? And the answer is, it depends on the jurisdiction. Ones that get used in debates are trying to reduce access to youth, trying to limit drug driving, trying to ensure good quality product. If you are a patient using marijuana with a compromised immune system, you want to know that the product you're consuming doesn't have mold, doesn't have pesticides. This is no-brainer in Washington State. In California, it's still a problem. We didn't pass testing rules until November, October of last year, and we've had a policy for 20 years. Product quality is something that we should care about from a public health perspective, understanding what's being consumed. And it's not just the mold and pesticide. We should care about what are the cannabinoids that are in a given product. We focus on THC, and there's focus on THC and CBD. Our science about the impacts of these cannabinoids is growing weekly. We don't know whether the other 80 cannabinoids matter or not, but if we aren't measuring them, how will we know? And then, obviously, we want to minimize concurrent use with alcohol and tobacco. That's generally understood as a good public health objective. Look, if marijuana is causing a bunch of 18 to 25-year-olds to not binge drink and just get high, and they don't get behind a wheel because they're feeling high and they just don't feel like going out, that's probably a public health win. There could be long-term effects that we should consider. But if you're concerned about drug driving, that's a realistic thing. What if it's instead, though, those 18 to 25-year-olds are drinking and smoking marijuana? Are we tracking that? Do we know? We have blood alcohol content surveys from our drug driving fatal accidents, and even there we aren't even sure if the people were actually using marijuana close to impairment. We need to be thinking about these sort of concerns when we're developing our policies and thinking about the data. What does it actually tell us? If our goals are the public health goals I just stated, reduce, let me go back because that wasn't very visible. Let's reduce youth access, prevent drunk driving, reduce potential for addiction and dependence, because I don't think anybody wants to create a new dependent substance. Regulate the quality and the content of what's being consumed and concurrent use. Then we can look at the alcohol and tobacco literature and say what policies were implemented in those two substances that were effective at accomplishing similar goals. So each of the columns represent one of the public health priorities. The rows are various successful approaches for alcohol and tobacco at minimizing or achieving the public health objective. Increased prices is a big thing. A 37% tax is a really helpful way to get you there. The problem is the 37% tax is on the retail price of the drug. And when the retail price of marijuana is falling from $25 per gram down to $8 per gram, 37% excise tax is also declining. Revenues will also decline. So your ability to keep prices high on an excise tax that's tied to a retail price might not work if prices in the market are changing. For the cost, then that's the cost of production price. That's different than the rest. Creating a state monopoly, no states decided to go this way with marijuana, but if the federal government changes its position, it would be a viable option, and it was successful for alcohol consumption, although I know in the case of Washington, there were some interesting anomalous findings for the change in their three-tier system. Restricting and monitoring the number of licenses, which Washington State is doing very closely on retail sales. Not so clear it's doing that for cultivation and processing. The question is, will it matter? The state doesn't allow deliveries. That could be good if you don't have cultivators doing deliveries and getting around the retail storefronts. If everybody's following the law, that's great. If there's loopholes and a tough way to enforce, you could have some issues. Limit the products sold. Again, this has not been an approach taken by any of the states. Alaska has been thinking quite seriously about this. They are concerned about people coming off the cruise ships and then going to sit town and getting waxes and oils and going back to the ship, not having a clue and using too much, and then them being legally responsible. Restricting public consumption. Washington law says not allowed to use in the general public. A bar restricts people under the age of 21, so that's not the general public. Can you use marijuana in a bar? There's definitely been episodes of it here in Washington, and there's some bars who are willing to let it go. Is that consistent with the public health goals of Washington State? It's a walk around. It's a walk around this policy because this wasn't explicitly considered in Washington's policy. It could be. It could be that they're fine with the way it is. And then measuring it and preventing impaired driving. That's a great thing to do and easy to do in the case of alcohol. We're finding it extremely difficult to do with marijuana. That doesn't mean we can't. It doesn't mean the technologies won't emerge, but it does mean that we have some work to do. The science has some work to do. Here's findings from one of the most recent Washington State, their financial management office produced their update on the impacts of legalization for the state. And AAA came out with their study suggesting that Washington State also had a rise in fatal auto accidents associated with marijuana episodes. This similarly shows the same thing for people who have died, but it didn't happen immediately with the policy change in January of 2013. Why? Because there was no market legally allowed at that point. There's a lag of about 9 months. Well, stores actually opened a bit later than that. But with the stores opening, we see an increase in fatalities associated with marijuana in the blood system. Now, does this mean that marijuana was the cause? No, it doesn't necessarily mean marijuana is the cause, especially given our current testing where we can't assess true impairment at the time of the fatality. And the problem in the Washington law is they get 2 hours before they have to go get their blood checked on average. So the ability to get at impairment is really still a challenge here in Washington State. What is interesting and important to note is among these people who are involved in a fatal crash, the vast majority have something in addition to marijuana in their system. Concurrent use with alcohol or other drugs could be a problem. Not definitively, because again, we don't know when the marijuana was consumed. But from a public health perspective, we need to understand this. So let's not pretend that marijuana is used by itself and is harmless, because people are just not going to use the other substances and just switch to marijuana. Because I think we're seeing data that suggests in other places, as well as Washington State, that there's presence of other substances, and we need to know whether it's being used simultaneously. Let me be clear, I keep saying concurrent. In the scientific literature, concurrent now is meaning used within the same 30-day period. That's not simultaneous use, and that doesn't mean that you're intoxicated by both at the same time. So the term simultaneous use is being used to identify use in the same use episode. In the case of tobacco, there's evidence in Connecticut, a state that has medical marijuana but hasn't legalized. 18% of teenagers are using e-cigarettes for marijuana, with marijuana. Blunts, in a study that was done on blunts, it was fascinating. The kids don't report using cigars. Cigar prevalence is going down. Blunt use is going up. Well, a blunt is a hollowed out cigar. And depending on how good they are at hollowing out, you may or may not be getting some of the tobacco. We need to monitor this. We need to know to what extent youth are using marijuana in conjunction with tobacco, because the public health problem from marijuana may be that we get an emerging new tobacco user, using less because they might not just be smoking cigarettes, but we don't know the long-term health impacts. Alcohol use, there is conflicting evidence. We do not know yet whether or not users use simultaneously, consistently. And part of the reason why is it depends on the type of user, depends on the age group, it depends on the purpose. We did a study comparing legalization to medical marijuana in Colorado and Washington to Oregon, who hadn't yet legalized, and New Mexico. Found that the vast majority of medical users don't use it with alcohol. So all that research examining the impact of medical marijuana laws on alcohol use, you're not talking about the medical users. You're talking about the recreational users who got away getting it in the medical marijuana system, in the medical marijuana policy. What we found was high, and I say high, meaning about 20% simultaneous use of alcohol and marijuana among recreational marijuana users. We now have a recreational marijuana policy. The history that we saw with medical marijuana might not be the indication of what we should be concerned about with alcohol and marijuana for a legalized system, depending on who was using in the medical marijuana system in the first place. The other thing that Washington State in particular needs to be concerned about is the potency of the marijuana that's being consumed. Washington is ahead of the curve, much higher potency on average in the types of marijuana products being consumed. Is that a problem? Well, it's definitely a problem for naive users, okay? But those aren't the vast majority of harms, but they're something that people should be aware of. Is higher potency a problem for the rest of the recreational users? We don't know, because we haven't been tracking it. We don't know whether higher potency matters. We know higher THC, they're more likely to be impaired driving, that much we know. But we don't know any of the other health implications. We know that there's probably higher risk of psychosis, but if it's high THC and high CBD, is there high risk of psychosis? Well, we don't know what people were consuming when they showed up in the ER with psychosis, so how do we answer that question? Poisonings, that's likely going to be correlated with a higher potency, because impairment can happen. And there has been a rise, again, this is Washington State data, in poison calls associated mostly with your opening of stores, not with the change of legalization in 2012. I keep harping on that because I'm really tired of seeing studies that evaluate the impact of legalization and they pretend that it all happened magically on January 1st, 2013. But it's also interesting to know in the state of Washington, the distribution of those poisoning calls. It's not just children in the state of Washington. Could these be naive users being introduced to the market? Yeah, it could be, but we don't know. And I think it would be useful to get some data and understand that. Because a public health campaign, if you care about risk of harm or ER visits, you should know that information. So in summary, what do we know? We know that marijuana laws are changing rapidly, and they continue to change, while the data to evaluate the impacts of these laws is not changing nearly as quickly. We need improved technology for understanding impairment. We need knowledge of product potency, which, by the way, in your seed to sale program, you can actually use. You actually have information, because they're testing the THC in the product. If you look closely at the distribution of the types of products being consumed, you can understand, are people choosing the lower, I'm just going to enjoy myself, 14 to 15% potency, which is consistent with the Netherlands coffee shops, or people consuming the high 22, 25% THC levels, which, by the way, are not allowed in the Netherlands. So the Netherlands, as an example, is only useful if you're going to start talking about a certain level of potency, which we haven't been talking about. We need to understand that when you study one form of legalization, Washington, Colorado, you're studying one form. I tried grouping the two studies together to look at impacts, and I saw very different things. Washington State, their prices were much higher to start with legalization than Colorado, because you guys didn't have commercialized dispensary system before you legalized. You started in a very different place. the impacts, the development, the focus on edibles right away, those sort of, the disallowance for home cultivation, that meant your experiment is different. And by the way, yeah, these are both commercialized systems, but the degree to which advertising is allowed is also a little bit different across the two. Compare that even to Washington, D.C., where it's only a home cultivation model. You can share your marijuana, you can't sell it in a store or otherwise. That's a very different model. Why do I keep emphasizing the fact that the form of the market matters? Because we know from tobacco and alcohol, the degree to which we have outlet density in the case of alcohol affects harms from alcohol use. We know the degree of marketing impacts alcohol abuse, even among teens who aren't supposed to be targeted by that advertising. Those sort of issues are likely to play a role in marijuana, and thinking ahead, you can devise a policy that is mindful of that. Washington State's policy is more mindful. That's good. Don't look at your effects pooled with Colorado. Don't look at them compared to California. What sort of things do we need to know? Well, I've harped on this. We need to know potency. We need to know what people are consuming. We need to know what products they're consuming. We need to know how much they're consuming. We need to know with what. We don't have good data tracking this information. We need to know how that use varies across different user groups. Let's stop paying attention to prevalence rates. Unless you're talking about 10th graders, it isn't that important. What matters is which products are they using and how much of those products are they consuming. Adults, we could be largely talking about the 1 glass of wine a day user. 18 to 25-year-olds, that's not how they drink alcohol. That's likely not how they're using marijuana. We need to be understanding of these differences, what matters, and are there public health implications from it? We need to know to what extent the policies that we're adopting influence the products being made available on the market, their safety, what's being promoted, where are the dispensaries getting the bulk of their sales from? If it's low potency marijuana, that's amazing. If it's high potency marijuana, then the idea that there aren't potentially implications for dependence are likely to be slim. Higher the potency, the more likely a user will become dependent. How is the market influencing that? How is the market influencing how people choose to consume? If it's believed to be harmless, how it was used when it was low potency marijuana and used in the privacy of the home, does that translate into low harms when they're using it in a bar, possibly with alcohol? We need to measure these things so that we can understand if those sort of analogies hold, or if we need to continue to revise our policy to reduce some potential public health harms associated with the policies. Thank you.
So we've modified the way in which we want to make questions available to our presenters, and that is that as you registered, you were given cards. So rather than to have people stand up in the absence of microphones, we'd like to see if there are questions, and if so, that you could write out your question and send it to the individuals coming down the sides of the aisles here, and we will have the opportunity to have Rosalie respond. Okay. So here's one. So regarding the recent study in Washington State looking at the increase in fatal crashes, is this a robust finding, or is it because we have not collected the data on THC's role in that process?
So even in the study that was published in Washington State, over half of the sample didn't have any THC reported. It wasn't included in the study and had to be imputed based on other characteristics. So is that a robust finding? How good is the imputation? I think it's as good as science could be at the moment. Is it perfect? No. Is the finding likely to be robust? It's consistent with what we're seeing in other states where THC has been tested more consistently in those states. Different states have different rules regarding the requirements for testing of blood in fatal accidents, and some states have been doing it for a lot longer. That said, our ability to infer impairment from the presence of THC is still emerging. But let's be honest. There are good clinical studies of people in simulators who are smoking marijuana and getting behind the wheel and do an imaginary, it's devised to set up to simulate real world, and they are significantly impaired. So yes, there is clearly a dose-response relationship and impairment associated with THC use in driving. Are we accurately measuring it right now using the technology we have in the blood? To answer that question, I think it takes a chemist to answer. I can't say definitively that it will continue to emerge, or yes, we've reached the current state of technology.
The second one is a basic one, and that is, what is CBD?
I'm sorry, I glossed over that, I'm sorry. So the cannabis plant has well over 80 different cannabinoids contained in it. One of them, CBD, cannabidiol, has been identified in numerous scientific studies as being a pain reliever of sorts. It operates in the system in a very positive way to help reduce some of the medical conditions associated with pain, muscle spasticity, and the like. So CBD is just one of the naturally occurring cannabinoids within the plant. It offsets the psychoactive effects of high THC. So in plants that are being used for medical purposes, those typically have high CBD levels. They might also have high THC levels, and if the ratio of THC to CBD is very similar, 1-to-1, the person doesn't necessarily get high smoking the marijuana, but they can still get all the medical benefits. What is a problem is in a lot of the jurisdictions, California included, there's been a botanical evolution of high THC plants, the psychoactive ingredient, and low CBD. That's not going to be as helpful for many of the medical conditions, most of which are being shown to be positively associated with high CBD. Those are only two of the cannabinoids in the plant. There are many, many more, and we are only just beginning to find out what the implication is, not just of each one individually, but the synergies of them. We need to understand that just like in any natural plant, it's the presence of two things together that can have a synergistic effect in terms of its impacts on the body.
How are positive effects of cannabis use reported and interpreted? Sort of, I guess the question would be, on the one hand, there's often a focus on the negative impacts. Yeah. What about the other side of that?
And again, I should have been more careful. From a public health perspective, we do care about the positive benefits of using marijuana. In the case of many patients, marijuana is being used very well as a sleep aid, and for some people to reduce anxiety. Of course, it depends which marijuana you're using, as in terms of whether or not it helps with anxiety or creates anxiety. Again, depending on the nature of the ingredients of the product you're using. We aren't doing a good job of measuring the beneficial effects of marijuana beyond the studies right now that are being done clinically to demonstrate medical benefit. We have done some analyses of willingness to pay to get marijuana as a proxy of what people perceive is the benefit to them. How much are they willing to pay in order to get this because they value it that much? If you do that and you look at black market prices that people are willing to pay, there's clearly a positive gain associated with marijuana use. And I think that's the impetus behind many of the policies. Are we talking about it in terms of the debate? No, because I think right now the move to legalization was mindful of that, and it's been less mindful. 80% marijuana is looking to be very consistent with alcohol. 80% of the users used at very low levels and in positive ways that don't have negative impacts on themselves or others. It's the 20% of users who represent 80% of the total quantity consumed that are the ones that create the harms. So from a public health perspective, we care about that 20% of users who are using 80% of the amount consumed. And by the way, when you sell, you're not paying attention to which member they are. You're paying attention to how much you sell, which is why the for-profit model is a risky model in terms of impacting potential negatives. There's other models for legalization that we try to make people aware of from a public health perspective, because those other models aren't operationalizing on getting profits, which means expanding use among the problem users.
Another question, given the federal prohibitions and restrictions on research, how is traditional knowledge accessed, and what links, if any, are there with respect to research from the marijuana industry?
This was a major discussion in a recent NIH Cannabis Summit that took place in March. The federal prohibition has had an impact on the types of study we can even do today, because universities that get federal dollars, it's not so much not NIH's dollars for doing research, but if you get federal dollars in general, then you have to follow federal laws. And so then the only way to do that sort of research is if you use federally sanctioned marijuana grown at the University of Mississippi, and that federally sanctioned marijuana has an average THC content of 5% or 7%, substantially below what is seen in the market. So researchers in Washington and Colorado, because of the policies that were adopted, had money for research that can support with state funds some of the same research using cannabis that's sold legally within the state. And I think we'll get to understand more in those states that have both the policy as well as the research dollars within the state to support funding for that work. The prohibition is something that has been a hindrance, but I say that knowing that we have also been very, very good. The federal government has been funding rat studies. They have been funding mice. They do know what the impact is in these sort of laboratory-controlled settings, and that research is getting out and informing what we're understanding about the beneficial effects of marijuana medicinally, as well as potential harmful effects.
How does cannabis calm anxiety or increase anxiety? And is there a way that people might be able to distinguish and differentiate those for whom it might do one or the other?
So here, you should probably go talk to a bud tender better. They might be more informed than I am. But my limited understanding in this regard is that anxiety can be subdued in individuals for products that have THC and CBD, equal amount of CBD. And the reason why is that the THC can take and help, it's not just anxiety, but PTSD, can help people suffering from these illnesses by having a little bit of the calming effect of the THC. But the CBD counters it and stops it from being too psychoactive. High THC can increase the risk of a consumer who's trying to use this for anxiety or PTSD, can increase the risk that they have a bad episode from it, because it can actually trigger worse anxiety. But I'm only talking about 2 of the chemicals. There might be 5 of the chemicals that really matter in the products. The bud tenders will tell you which products are better for certain conditions, and we need to understand what's in those products to know what is it about the chemical makeup of them. When we study it in rats in labs, right now it's the combination of high CBD with high THC.
Another question, what is the impact of aroma of cannabis, like secondhand smoke? And should we be concerned in the same way about secondhand marijuana smoke as has been true of tobacco?
So I can tell you, as somebody with long hair, and the fact that smoke does get absorbed in the hair, and I have a federal clearance that I don't want to lose, that the whole idea of secondhand smoke does scare me, because I can lose my federal clearance, which is secret. I don't want to lose that. I think people who are in federal roles or have federal jobs care a lot in terms of their exposure in that regard of risk. In terms of health risk, I know that people are interested in. I'm not aware of studies. That doesn't mean that they aren't there, but I know that people are interested in understanding it. Of course, just like e-cigarettes, the exposure is going to depend on how the product's being consumed. The case of marijuana, you have other forms of products. So again, if you're worried about smoke, that you could say, okay, no combustion in public setting. That doesn't mean that they can't use an e-cigarette or an edible in public.
How do we take seriously the claim that cannabis is a traditional medicinal and cultural heritage plant based on extant practices in South Asia, which have diffused globally with migration over the last 2 centuries?
That's absolutely correct. It's been a medicine way longer than it's been prohibited in most countries. I don't think that people are negating that. And I think that the difference is that the standards of science today are very, very different than they were 100 years ago. And things that we thought were healthy then, science has shown is not necessarily as healthy as we thought. Tobacco? That doesn't mean marijuana is tobacco. I don't mean to imply that by any means. What I mean is that just because something was used in the past medicinally for therapeutic benefits doesn't mean it's the best option today, given the other technologies that have evolved. When we have things like Sativex that can provide, which not allowed in the US, but allowed in Canada and Europe, that can provide strict doses of the exact mix of cannabinoids necessary to improve your health condition. Why is that not preferred to a naturally occurring plant, which, depending on the amount of rain or the amount of sun exposure or the amount of anything, the type of fertilizer, can have a completely different mix contained in it in terms of its potency and the mix of the different cannabinoids, not to mention the botanical start of the plant. So you're talking about a product that's highly variable naturally. From a medical standpoint, I think medicine has evolved to try to get more precision in dosing. And that's why a lot of people in this debate don't talk about the plant as medicine, because they're used to a more precision-based delivery form of medicine to the consumer, to the patient.
So we're out of time for our questions. We have a whole stack still there. So what we would hope to do is to take these with us and post them maybe with the slides and so on, so at least people can see what the questions were. And it also may serve as, again, sort of a stepping off point for researchers to see what the questions are, to help form ideas about how to go about addressing them. So it's time for our break. We go until 10:30, I believe, for our break. So please come back, and we will begin with the next set of presentations, which focus, again, more on the local policies around marijuana use. So thank you. Thank you. So what I would like to do is to introduce our next moderator, who will then introduce the speakers as they come up to speak. Our moderator for this session is Mark Cook. Mark actually was, I think, the first speaker in our November 2013 symposium. And so he did such a good job, I'm embarrassing him now, that we wanted to have him come back. But Mark is really a very appropriate individual to be moderating this particular panel. Mark is the policy director for the ACLU of Washington. His focus is on the Campaign for Smart Justice. The other thing that's important to know about Mark is that he really has focused on issues around criminal justice, drug and mental health policy issues, and in particular around issues having to do with marijuana, its legalization, and the policies surrounding that. He was a member of the group it was called the New Approach Washington, which was really the group that helped facilitate the development and the passage of I-502. So he has been able to see it from its sort of beginnings, really, to now it's having been implemented. And yet, as we heard and we will hear here in this panel, there continue to be issues, questions, and opportunities. So, Mark.
Thank you, Dennis. Good morning. My name is Mark Cook. I'm with the ACLU of Washington. I have the great privilege of introducing four wonderful speakers who will be talking about the implementation of Initiative 502, which was the law that legalized and regulated marijuana in Washington state. As one just kind of logistical note, as the speakers are going to come up, if you have questions, please grab a note card and write down your questions, and we'll collect those at the end for a moderated Q&A session. I also just wanted to add one historical note before I bring up our first speaker, and that is when I-502 was being drafted, there was no expectation that it was going to be a perfect policy, and that it was always going to be a dynamic policy in need of constant change and fine-tuning. And what you'll hear about from the speakers today is, what does that look like so far, and where are we going to be going in the future? And I think it's incumbent upon the regulators and the researchers in this room to identify the problem areas of the law and recommend to lawmakers what the changes need to be. So with that, I'm very honored to introduce our first speaker, who is Rick Garza. He is the director of the Washington State Liquor and Cannabis Board. Rick has been with the LCB since 1997 and has been the director since 2013. Prior to that, he served for 13 years as a staff member for the Washington State Legislature. That is really God's work, Rick. 5 years with the Senate and 8 years with the House. He is also the past president of the National Conference of State Liquor Administrators, and he will be talking about the implementation of I-502 over the last few years. Welcome, Rick.
Good morning. Thanks for the introduction. Great to be here today. I have a couple of staff folks here from the Liquor and Cannabis Board, and I have one of my bosses here, so I better make sure I acknowledge her. Ruth Ann Karose is one of our 3 board members. She's with us today. Also, Mary Sagawa, who some of you should know. She's our public health education liaison, has been with the board for many years, and before that, worked with a community-based organization in Thurston County called Together, if you know the happenings of that in Washington. And then also, Lucy Peterson, one of our liquor and cannabis enforcement officers, is here. We try to bring staff in. Believe it or not, we do these presentations about once or twice a week, or I should say I do. So I've got about 20 minutes. I'm trying to keep all these slides maybe to 15 so that others can speak and also give you an opportunity to ask questions. So I think the only thing I need help with technology-wise is making this a little larger for me. Is there someone that can help?
Here?
Yeah.
Unfortunately, no, I can't.
Oh, you can't.
Yeah. So I could.
Okay, I'll lower my glasses. That'll work. It'll have to. Thank you. So today I'm going to talk, what were the objectives of the agency with respect to implementation after passage in November of 2012, licensing requirements, consumer safety elements, the sales activity to date, what we know, what we don't know, and then I'll share with you something that you can look to, which is a Brookings Institute study that was done soon after legalization, comparing Colorado and Washington's experiment, and then how you can stay connected with the board. So obviously, in November of 2012, a legalized system was approved by voters for producing, processing, retailing marijuana for adults 21 and older, decriminalized possession of 1 ounce of marijuana you see in their forms, and then created a 3-tier system of licensing, regulation, and taxation. Let me share very quickly, and it was soon after the law passed that I sat down with Allison Holcomb, the author, the ACLU policy director here in Washington, who wrote the initiative, to understand. I mean, we did public forums actually for a year. So the law required that by December of the next year, which gave us a little over a year to write regulations to implement I-502. I soon met with Allison to say, Allison, you gave it to the Liquor Control Board at the time. And so there were questions earlier with the guest speaker about what's the model. And so I'll share with you, you're going to see in the information that I'm providing that this model is the alcohol beverage law, really, of 1933. So after Prohibition, there was a three-tier system that was created because of the abuses of saloons. And it basically said, and you'll see it in this law, and you won't see it anywhere else around the country, that there has to be a separation between the three tiers. So before Prohibition, believe it or not, the saloons were controlled by the largest brewers and large distillers and brewers in the nation. And so after Prohibition, the 21st Amendment, they allowed the states to determine how they were going to regulate. So whether you're a control state or an open state or a licensed state like California, the federal law still has this foundation that says there has to be separation of the three tiers. So a producer and processor of cannabis can have no interest, direct or indirect, financially in a retailer. And a retailer can have no interest financially between a producer and a processor. And you go back and talk to Allison Holcomb about that, and it was to create that separation, the concern that one company would control cannabis marketplace. And I'll share with you some of the controls that we put in place. For example, if I'm a producer processor, I can hold no more than 3 licenses in the state. If I'm a retailer of marijuana, I can hold no more than 3 licenses. Again, the intent of the initiative in discussions with the proponents was to allow as many people into the marketplace, but keeping the farms, the processors, and the retailers small. And so we created a 3-tier system of licensing, regulation, and taxation. And I'll have you look at the first figures. You know, when the Office of Financial Management was required to write a fiscal impact statement of I-502, as it is for all initiatives and referendums, they assumed excise taxes of $0 to $2 billion over 5 years. So you laugh about that because it's really kind of funny. So what did people glom onto? They didn't glom onto 0. They glommed onto $2 billion over 5 years. I'll share with you what that looks like now that we've been in the marketplace July 1st for 2 years and what it looks like. But keep an eye on that 36.3 million, which was the forecast after the first year. There were also public safety and education. It established a 5 nanogram THC bloodstream threshold for marijuana, limits on store locations, advertising, the number of outlets, the controls that you were hearing about earlier, and then earmarks revenue for healthcare research and education, and I'll share with you what that looks like. So really the objective was to create a tightly controlled and regulated marijuana marketplace, and you can see the responsibilities that we had. But I'll share with you specifically, so what's the biggest challenge that we had? So like Colorado, for 9 months until August of 2013, we had no idea whether the federal government was going to allow this to move forward. And so while we did consult with the U.S. attorneys both on this side of the state and in eastern Washington, they didn't really share a lot of information with us other than they felt it needed to be strictly regulated. And so really, if you look at the Cole Memorandum that was published in August of 2013, I'd break it up into 3 specific areas of concern. 1, diversion. How are you going to ensure us that the system that you're creating doesn't divert marijuana out of the state or invert illegal marijuana into the legal system that you're creating? And I'll share with you how we think we did that. Number 2, how are you going to keep marijuana out of the hands of kids? Of course, you have to be 21 or older to consume or possess. And then number 3, how are you going to keep your system from licensing or having criminals, cartels not involved in the system? So I'll share specifically how we did that. But first of all, we didn't know what we were doing when we got involved in this experiment. So we actually went out with an RFP, and many of you may be familiar with Dr. Mark Kleiman and Botech. He also then contracted, had 4 subcontractees, one of them Dr. Bo Kilmer with the Rand Corporation, who helped us determine what we had to do, which was basically the law said the board had to determine what was the need for Washington. In other words, if we're not going to divert product out of the state, then we actually had to survey by county what the consumption of marijuana is for those over 21. And believe it or not, Rand Corporation helped us come up with that figure. If I remember correctly, it was about 140 tons for the state. And from that, we built the system behind that. How many producers and processors, how much canopy would we build, and then how many retail stores that we have. And so remember, here's the irony of the voters. So in 2011, what did they do? They took the spirits out of the business for the state of Washington. Then the next year, what did they do? They hand us cannabis regulation. And so, but it's important because the system that we had for liquor stores, believe it or not, we had to determine the number of retail outlets statewide. What did we use? We used the old liquor store model, which was 334 liquor stores statewide. So it's interesting to note that the business before the state lost it in 2011 was almost $1 billion in spirit sales. So remember that figure, almost $1 billion in spirit sales the last year. And so the licensing requirements. So it's interesting that it's changed over time as far as alcohol licensing, but initially you had to go through a fingerprint in order to hold a license for liquor. You as the applicant had to be fingerprinted. This law was even more cumbersome in that any applicant, any person that was a party of interest to the license has to go through a fingerprint through the Washington State Patrol, and then obviously through the FBI, we do a national search. And then any investor, any financier has to also go through a criminal background check and be fingerprinted both for the state and against the FBI database. Financial background interviews. So we actually asked the applicant, where did you get the money to create the business? We look for bank accounts. We get those accounts. We look for their source of funds. We do that for alcohol also. And then there's a 6-month residency requirement. Initially, the initiative had 3 months. The legislature amended it to 6 months last year. And then you had to show right to property, either a lease agreement for where you're going to set up your business. And then the traceability system, the seed to sell program that we have, like Colorado, was the way that we believe we were able to ensure that product isn't being diverted out or in. And so that's a pretty robust, pretty expensive system that producers, processors, and retailers, security, also cameras throughout the building, in every room if you're a producer or processors, and then daily reporting by retailers, similar to the liquor system that we had for state and contract liquor stores. Strict packaging and labeling requirements. So we were a little behind Colorado, about 6 months from when they opened their first retail outlet. So remember, there's a distinct difference between Washington and Colorado in a lot of ways. One is, and in all the other states, vertical integration is allowed. I can be a producer, a processor, and a dispensary, for example, in Colorado. What they did was simply give those with medical licenses a recreational license. That's how they got started a little earlier. The problem with our system was there is no vertical integration allowed. So it took about two sessions of the legislature, because obviously if you were in the medical business, if you were cultivating, processing, and dispensing, the last thing, honestly, that a lot of them wanted to do was walk into I-502. That's not the system that allows for no vertical integration. There was a lot of concerns about moving into the recreational system. But as we learned in Colorado, there were issues with respect to potency initially. And so we set pretty strict packaging and labeling requirements. I'm sharing with you here on that slide what that looks like. One of the things we didn't know, and I think the difficulty that we had, is we had a competing, unregulated medical marketplace out there when we started. Basically, we found things like gummy bears, lollipops, cotton candy were being sold in medical dispensaries, bright colors, even candies, if you look to the left of the slide, that mimic candies that are out there that kids consume. So we put pretty strict, immediately by emergency rule, the board adopted language that said anything that's especially appealing to children cannot be sold as is infused or edible. We actually have a 4-person committee. Mary's one of the people on that committee that actually have to approve all package, all labeling, and then all product before it moves through the system. Here's an example of the packaging that you'll see in the marketplace. All product is tested for consumer safety. There are store signage and product warnings, no minors. Again, like our liquor store model before 2011, no one under 21 can enter our recreational marketplace. Just give you an idea of what it looks like today, 935 producer processor licenses. As you can see, most people hold both a producer and a processor license, and then 250 retail outlets that are reporting sales. As you know, legislation was passed a year ago to reconcile medical and recreational. In October of last year, the board determined that we would allow 222 more retail locations statewide. That brings us to a little over 500. As we continue to issue licenses, we'll be doing that for the next 6 months to a year, but likely we'll get up to probably around 400, because one of the issues and challenges I'll share is that we have bans and moratorias across counties and cities around the state, most dominantly in eastern Washington. And so if you go, there's actually a dashboard at our website. And so at the end, I'm going to tell you to go to our website, because we have a lot of information. A lot of people ask questions about where are these producer processors and retailers located. If you go to the dashboard on our website, you can actually click on those dots. They'll give you the address. They'll give you information about who the owner is. That's all public information. Our sales activity today, so actually just a couple of weeks ago, we hit $1 billion in sales. You can see that the revenue that we looked at, remember, 36 million was the estimate initially. We actually hit 64.9 million in excise taxes the first year. And while that says 151 for this year, it'll probably be around 164. And so if you look at current revenue projections for that 5-year period, it's interesting. Remember, it was a 0 to 2 billion. It's likely to hit somewhere around 1.2 billion over 5 years in the excise tax. And then a lot of people ask the obvious question, so where does the money go? One of the things I asked Mary to do for me for this slide was on the left, you'll see what I-502 appropriated, or the percentages for each of the agencies that are listed there. And so, as you probably know, there was quite concern about the fact that the legislature, obviously the state has a budget crunch and a hole, used part of the revenues that were supposed to go to the entities that were listed in higher percentages because they needed to fill their hole. So if you look at the last slide, you'll see that the general fund for the state in the initiative was supposed to receive 16.7% of the revenues, and in fact has received 33, as you can see, and 31 for the current biennium, which meant that all the other disbursements were less. Typically, what I'm seeing there is about half what they were supposed to receive. So obviously that's of concern to many of the agencies that were looking for revenues from the initiative. Specifically, I'll share with you, and you're probably well aware more than myself, with respect to DSHS and substance abuse prevention and treatment, the increases in budget there. The Department of Health recently, as you probably know, just began a campaign with respect to folks under 21 and youth, and then also an education campaign for parents. I don't think I need to go into the specifics of that. So daily sales growth. As we continue to issue grower and processor licenses and continue to issue retail licenses, we've seen continued growth in the business. Someone had said earlier, we started at about $30 a gram 2 years ago because the supply was low. Now we've gotten to, I believe, with the excise tax included of 37%, about $9.30 a gram. And that's actually starting to stabilize now, but it has been dropping for the last year. And actually, we believe competes with the unregulated medical that actually ends July 1st, and probably you can get a gram in the black market somewhere between $6 and $8 a gram, if not cheaper. A lot of people ask, so what are the sales? So interesting, unlike Colorado, about 73% of the sales is actually bud or usable marijuana, the dry bud, and not so much, as you see in Colorado, concentrates and the rest. So obviously the biggest issue has been the fact that we conflict with federal law. That continues to be the challenge for a lot of reasons. One is banking is difficult, though not as tough as it is in Colorado. We have 5 regional credit unions that provide banking services for the industry. I know Colorado has struggled with that. We have bans and moratorias, which are beginning to lift. In fact, a few days ago, Mary told me on the drive up that Yakima, the city of Yakima, is ready to lift its ban. But we also are dealing with the issue of pesticides and making sure that, in fact, the product is safe. I've used up my time, so I'm not going to be able to get any further, but hopefully with questions I can provide more information. Actually, the Washington Institute for Public Policy at the Evergreen State College, I think I saw a couple of the folks here, Adam, are required to provide you with surveys, I think, every year or maybe next year. Is that right, Adam? So that's an important revenue that was provided to the Evergreen State College and the Institute for Public Policy to look at the benefit cost analysis. I take you to the Brookings Institute if you ever get a chance to look at that. I think Philip Walnick, though long, did a comprehensive review of the benefits and maybe not the benefits of the systems that were created in Washington and Colorado. I think the difference between both, very quickly, is that ours is much more strictly regulated. Our system in Washington compared to Colorado. I think we're seeing that Oregon and Alaska, again, are using the control state model. It's the liquor boards in Alaska and Oregon that are regulating it. So thank you.
Thank you, Rick. And I don't know, do I just advance the next slide to get to? Okay. Okay, great. So our next speaker is Chris Baumgartner. He is the Drug Systems Director at the Washington State Department of Health. Prior to his appointment in that position, he served in various capacities for 10 years at DOH, including working as the Prescription Monitoring Program Director. He's also formerly worked for the Washington State Department of Social and Health Services and as an IT Portfolio Analyst and Prescription Monitoring Program Director for the state of Maine. He will be presenting on Washington's medical marijuana program. Welcome, Chris.
Well, thank you. I appreciate the opportunity to be here today. And I'm just going to take you through what we've been working on at the Department of Health. It's been kind of interesting because from our perspective, while medical marijuana law came into play back in 1998, we really haven't had a whole lot of a role in marijuana policy in our state, except for the brief stint in 2008 with the 60-day supply rules, which were later put into law, and then we kind of didn't have much of a role again. So under 5052, which passed last year, the Department of Health was given quite a few to-dos. And so these are the things I'm going to try to provide you information on today. A standard authorization form for the state, a mechanism for reporting 30 or more authorizations. Reports, we have 3 of them that are due, 2 are already turned in. Continuing education for authorizing healthcare professionals. Our product standard rules for medical products. Our database rules and system, and then rules for a new credential, a medical marijuana consultant. So as far as the authorization form, that was kind of our first big to-do after the Governor Inslee signed this back last April. It was posted to our website in late June for fear that the government shutdown would prevent us from getting it done. Thankfully, that did not occur. And so basically, before there was no standard authorization form, so it became very challenging for dispensaries, for law enforcement to know, is this authorization valid? Because it literally could look like anything. So this is now on our website. It must be used for all new authorizations or renewals beginning July 24th of last year. And the big kicker is this July, all authorizations must be on it at that point. Authorizations, again, on any other form at that point are invalid, whether or not the expiration date for that authorization has been reached or not. So that's really important to recognize. So that is up. We are looking at some ways to streamline it based on what we've learned so far over its use over the first year. But it is up and available and has been for almost a year. Legislative reports. Actually, let me back up real quick. The more than 30, real quick, it was an interesting stopgap measure the legislature put in place before our medical marijuana database came into play, which is coming in July 1st. And it basically said if you authorize more than 30 authorizations in a month as a healthcare professional, you have to report that to the Department of Health for the first year. So we basically stood up a web portal where providers can report those to us and we can take a look at those. And that, again, goes away here at the end of June and gets basically replaced by the authorization database. So our 3 reports that we worked on this year, one that is upcoming, is recommendations on specialty clinics was the first one that had to be completed. And that was kind of the concept of should the state support the idea of allowing an integrated model where a healthcare professional who can authorize can also dispense from the same clinic. Due to the current federal prohibitions and several other considerations, our recommendation at this time was no, and that report is on our website if you want to look at it. We were also given an interesting clause in Governor Inslee's veto message on the bill where it looked at rescheduling marijuana. He vetoed that section but asked the Department of Health to look at rescheduling marijuana or considering whether or not it should remain as Schedule I in Washington State. We looked at several different options, held a stakeholder meeting, consulted with the Pharmacy Commission within our department who oversees our Controlled Substances Act, and put out a report in January of 2016 indicating that, again, due to kind of the same problems, especially the federal prohibition and federal status of it as a Schedule I drug, that our recommendation would not be to reschedule it at this time. Our final report that's due this November is to the legislature basically on the cost of implementing the database, and so that is something that we are going to be working on very soon. Practitioner continuing education was the next component on my list, and basically the law requires the 2 boards and 2 commissions, so Medical Commission, Nursing Commission, Osteopathic Board, and the Naturopathy Board to basically collaboratively pull together and try to come up with a continuing education model for those who can authorize for the medical use of marijuana. The interesting part is the law doesn't require anyone to take the continuing education when that's created. It just says you have to make some available. So the boards and commissions had already put together some authorization practice guidelines. Those are on our website if any of you want to take a look at those. I've also understood those have been adopted by the Federal State Medical Boards, the Federation of State Medical Boards, FSMB, so hopefully that means we did a decent job with them. And basically the goal is to try to create some continuing education around those practice guidelines that have already been put in place. The boards and commissions are still working through that piece and looking at what they think will work best to meet that legislative requirement. The first set of rules that we got put into place were by emergency, and that was back on October 5th of last year for product compliance. And so we were charged by the legislature to come up with basically products that had additional quality assurance standards for patients to help them feel extra sure that what they were getting was going to be safe, consistent, and a quality product that they could use. And so the reason we filed emergency rules was really to try to help ensure that the producers and processors had enough time to prepare these products and have them ready for market by July 1st. And so we filed those documents again back on October 5th. They cover a lot of things around labeling, testing, safe handling, and employee training. And so we are now on our 3rd iteration, I believe, of those rules. We just filed them again, actually, this week. So if you take a look at our website, those will be available, I think, soon if they aren't already. And we are still working on permanently putting those rules into place. It's been kind of an ever-evolving process as we learn more. So to give you an idea about, again, what's in those, these are the labels that will be used, that were developed. And Again, the big things are quality assurance testing around pesticides, heavy metals and mycotoxins, labeling, safe handling, and employee training. And you can see we came up with three kind of areas of products. One is high THC. Those are available to medical card holders only. General use are basically other products already available in 502 stores that have gone through the additional requirements of our rules for testing and labeling. And then finally, high CBD products. It was actually an outcropping of House Bill 2136, which said we had to also create products that were high CBD and available sales tax-free to any adult consumer. So those products will be available to any adult consumer sales tax-free. And so those are the three key categories of products that you will find in our rules. The next big thing that we are working on still and putting into place, we actually just filed our permanent rules for the database this week, so those also should be available on our website very shortly for review. And so the authorization database, for those of you who may be confused, it is what we would call the registry in our state. That's not the label the department had from the legislature for it, but that's basically the equivalent. And so retailers with medical endorsements are allowed to add qualifying patients and their designated providers who wish to participate into the database. It's required if you're under 18, but it's actually voluntary if you're 18 or over to be in the database. And then various entities have access to that information for specific purposes under the law. So authorizing healthcare professionals may look at that information as they provide patient care. Law enforcement to validate a card, to make sure that someone's allowed to, for example, to have the plants in their car or additional possession amounts. The Department of Revenue for verifying the sales tax exemptions, as well as the Liquor and Cannabis Board by the retail stores. And the law actually also specifically allows, which is kind of, I think, of interest and kind of different, qualifying patients are actually allowed to ask us who has queried my card. And we have to provide them a list of the person and entities who have made access and looked into that. So that's an interesting side effect. Obviously, the stores also validate the cards for the purpose of sales tax-free purchases and additional purchase amounts that are allowed. So a quick idea about what the program looks like. It's very different than other states. Most of the other states, the patient applies to a card to the state agency, or the authorizing healthcare practitioner might be involved in putting them into the database. Again, Washington, we do it a little different here. So the authorization is taken to, again, a medically endorsed store. The card holder is entered into the database, and a card is there on-site printed, laminated, and provided for the card holder. And then, again, authorized personnel for various reasons are allowed to view that information through our system. This is a rough mock-up of what the recognition card is going to look like. You can see this one is for a minor patient, so that the stores can be aware that this person must be accompanied by a designated provider when they enter the store. It has a unique randomly generated number, their name, effective date and expiration date, the plant limit that was assigned by their authorizing healthcare practitioner, and the name of the authorizing healthcare practitioner. On the back of the card is a 2D and a 1D barcode for making it easier to validate the card through scanning it. The transactions amounts, which are 3 times the recreational limits, are on the back, as well as some information around being reminded that this is not to be used as a photo ID, and that this card is not allowed to be duplicated except where allowed by law, and that's when you're participating in a cooperative. So what are the big benefits if you have a card or if you don't? Because again, if you're 18 or over, the choice is yours. You do not have to be in the database, but there are some pretty significant things you lose out on. Cardholders may purchase 3 times the recreational amounts, may possess up to 6 plants, at least 6 plants and up to 15 if authorized by their healthcare professional. Their purchases, again, are sales tax-free. They have arrest protection rather than just affirmative defense. And they may participate in a cooperative, which is replacing collective gardens, and can be up to 4 individuals who are allowed to grow together. And so those, again, I also mentioned before, though, the other one is the high THC products are only available to cardholders. So again, just as a reminder, this is the recreational limits versus the medical limits across the different products types. It's just, again, 3 times for each category. So the other new piece we've been working on very hard recently, and has been a very interesting part of this whole endeavor, is a medical marijuana consultant. And so the way the law is worded is this is a new credential established by the Department of Health. We currently regulate over 80 different health professional types, everything from medical doctors down to animal massage therapy, believe it or not. And this is a new one. It's not under the Health Professional Uniform Disciplinary Act. It is more of a, not necessarily a true, complete health professional credential, but these are folks who work in a medically endorsed store and have gone through additional training and certification from the Department of Health to provide services and assistance to patients and designated providers within the store only. And so one of the first things we had to do after getting our rules in place was the law requires us to establish training programs for the consultants to take. The law specified several different types of topics that had to be instructed upon, and most of them are up here. We added a few around ethics and privacy rights with our rulemaking process, and as well as added hours for how many hours had to be taken on each topic. And to date, just so you know, in case you were curious, we have approved 2 training programs. Those are available on our website, and they can be contacted if anyone's interested in taking training and becoming certified as a medical marijuana consultant in our state. Whoops, sorry. So what can a medical marijuana consultant do? What are kind of the bounds of the practice or their scope when they're working? So they can only provide services within a medically endorsed store. That's the first important thing to really note. And they, the kind of the biggest area that we're struggling with, as you can imagine, is they're not allowed to be a healthcare practitioner. So they can't recommend changing treatment. They can't say, you know, these products in here mean you don't have to see your regular doctor anymore and you don't need, you know, any additional medical attention. It's really focused around assisting with product selection, describing different routes of administration to the patients, giving them some ideas about how to properly handle and store these products, and more along those kinds of lines, helping them with finding products that might best meet their medical conditions. So again, they're not allowed to diagnose any condition or recommend modification or elimination of any treatment involving unless it involves not involving the medical use of marijuana. So that's where I know our health profession community, I think, has the most concern. You know, they really don't want someone going into a store and again being told, hey, you don't need to see your doctor anymore. You know, I got you covered. And so it's going to be really interesting to see how this new credential plays out, especially with the fact of that careful balance that has to be maintained. So one thing that we've tried to do to try to really help people navigate this new system that's going to start July 1st is really trying to look at, well, once you're in that store, if you have a card or you don't have a card, what are you able to do? And so we're hoping this kind of helps. This is the diagram we created. So again, there's kind of 4 different product category areas. 3 are the ones that are in our product rules, and then there's the other products that are currently available just based under the LCB rules that are available in any 502 store. And so basically the best way to look at it is if you have only an authorization form as a patient, you've chosen not to be in the database, then basically you are treated like any other adult consumer within that store. The only other advantage you get is the same one everyone else does, and that is those high CBD products are sales tax free to you if you want to purchase them. But other than that, the only other benefit really, again, that just the authorization form provides you is you can grow at home at least 4 plants. With the card within the store, though, then you have access again to high THC products, which are not available to non-card holders. And again, all your purchases there are sales tax free at 3 times the recreational limit. So hopefully that kind of helps just with that understanding of what is it going to look like on July 1st if you walk into that store, whether you have a card or not, whether you're a patient or not. This is basically the way it all shakes out when you look at the laws and rules at play. So that's just a high-level overview of what we're working on at the Department of Health. I do want to mention, too, just quickly with the consultant, that application is available as well. So not only are the training programs available, but the actual application to apply to become a consultant is up. And the reason that's really important is under LCB rule, each medically endorsed store has to have on staff at least 1 consultant. And the other is in our database rules, we require that a consultant is the only one who can enter someone into the database. And we felt that was really important. That is actually something we heard very strongly from the patient community at our stakeholder meetings, was that, if we're going to go into a recreational store as a patient, we're going to feel a lot better about working with someone there and talking about our condition if it's someone who has some level of training and some sort of accountability, credibility, and this credential was going to help them feel better about that. So that is actually part of our database rules, is that the only ones who can create cards for patients or their designated providers are someone holding a medical marijuana consultant certificate from the department. So at the Department of Health, our primary team within the medical marijuana program, I have, again, multiple programs within my section, but I'm available as the director. Susan Reynolds is our operations manager. She's holding down the fort today. Kathy Tedrick is with us, who worked on the logos and is our communications coordinator, and I'd be happy to introduce you to her. She is also great at holding down our phones in the fort, but she's doing a lot of our communications work. That's our main line, our email address, and our website. If you're trying to get to any of our information, there's also a listserv there that you can sign up for. That information is getting updated constantly, as you can imagine, as we race towards July 1st. So definitely, if you're interested in trying to keep track of what we have going on, the listserv and our website are definitely preferred methods. And I appreciate, again, the opportunity. Thank you.
Okay, thank you, Chris. So next up, we have Rion Ramirez, who is the General Counsel for Port Madison Enterprises, which is the economic development arm of the Suquamish tribe. Before that, Rion worked at the firm of Dorsey and Whitney, focusing on Indian law, tribal finance, business law, and gaming. In 2013, Rion was appointed by President Obama to serve as a commissioner on the President's Commission on White House Fellowships, and he holds his degrees of BA and JD from the University of Washington. Go Huskies. And he will be talking about marijuana in Indian country, fact, fiction, and reality. Welcome, Rion.
Well, good morning to you all. One of the things we haven't really talked about is, Indian country at all. I mean, the state of Washington went through their legalization efforts, and those legalization efforts didn't take into account or any kind of consultation or anything associated with Indian country in that regard. And we in Indian country in Washington state were left in a situation where we had the state do their legalization efforts, and we had people coming into our facilities, whether our casino or other establishments that we had, and breaking out bags of weed and, not necessarily rolling joints per se, but carrying weed in their pocket or what have you. And we would call the cops to come in and deal with those folks, and the non-Indian police officers, the sheriffs, and the county officers would come in and say, well, really, what do you want us to do? I mean, they're not smoking weed. You can refuse them service. They got under an ounce. What do you want us to do? And so we started to have a lot of discussions in regards to marijuana and what the tribe was going to do in regards to it. We had, all these community meetings and a lot of different stuff going on. And we ultimately decided that if the state was going to be willing to work with us, that we thought an integrated system between the tribal government and the state system would ultimately be the best solution. And, it promoted a lot of good things, but we had a lot of ups and downs in terms of dealing with the state. We aggressively went out very, very, very early on to talk to the state in regards to the legalization efforts. I went to D.C., met with DOJ, I met with the Bureau of Indian Affairs, met with, we have another organization called NIGC, the National Indian Gaming Commission, that oversees our gaming stuff on a federal level, met with them, and those kind of conversations at the federal level were kind of interesting, considering that when I met with the Department of Interior and the Bureau of Indian Affairs, first off, before I even left, we had emails from the head of enforcement for BIA contacting our cops and saying, what the hell are you guys doing? And and our tribal, our chief of police responding back to him going, well, he's out there for tribal council. What do you want me to say? But ultimately, we decided to move forward, and here's kind of the steps and stuff and how things have progressed. First off, the state, passed I-502 again without any kind of consultation or any discussion of Indian country at all. It decriminalized marijuana, functionally making it civil regulatory for us in terms of Indian country, for us to regulate and pretty much deal with however we felt fit. Folks, Rick had mentioned in regards to the Cole Memo. The Cole Memo was issued in terms of shortly before the legalization stuff started at the state level here, basically to give the states some cover. It's not a law. It's a policy. I mean, it's just a memo from DOJ. They can turn it around and change their mind anytime they want. But again, DOJ, when they issued the Cole Memo and the 8 priority areas, and the 8 priority areas just fundamentally mean that if you don't fall into one of these 8 categories, we're going to take prosecutorial discretion and not go after you. It doesn't mean it's not a crime. It's still a Schedule I drug. It's still federally prohibited. It's still bad, bad, bad. There are lots of people serving time for marijuana. But as you go through, there were, 2 areas that are called out in here that potentially could potentially be viewed as impacting Indian country. One, public lands and federal property. The Cole Memo, really promoted the idea of tracking and of marijuana from seed to sale, not only in law, but in actual practice. The Cole Memo, referenced states and local governments, but didn't say anything in terms of tribes. And as I mentioned, public lands and federal property were areas that some at the state, Rick Garza, saw as potential areas of concern in terms of our discussions. And during those discussions, I've had a lot of dealings with the feds and have a lot of long-lasting relationships in terms of doing a lot of things for the Obama administration and a lot of stuff. And I said, I'll carry the water and I will get DOJ to give us some kind of clarification in terms of how DOJ is going to treat Indian country. I think some were skeptical that I'd get some clarification because it was hard for the states to get it and it wasn't easy for us in Indian country to get it. But ultimately, dun, 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 we got what's called the Wilkinson Memo. The Wilkinson Memo was issued, and when it came out, it attempted to address Indian country. If you read it, it's even more opaque than the Cole Memo. But what it did attempt to do is just highlight that Indian country was going to be treated the same as states, really, in terms of the legalization efforts. What that memo meant initially, you had a lot of reports in, the LA Times all over across the country saying, marijuana is legal in Indian country. And no, it's not. But, and you had a lot of profiteers running in, trying to promote the idea that Indians could, we in Indian country as tribal governments could do a lot of things that really weren't true. You had DOJ in response to that, starting to get out and make presentations and make clear that it didn't legalize marijuana in Indian country, but that you're going to treat tribal governments like the governments they are, similar to state governments, and work with them in terms of this grand experiment that we got going on here in Washington, Oregon, coming up, and Colorado. But they were going to work with them on a government-to-government basis. And, so we continued on down that line. You had a number of DOJ actions associated with some of the concerning conduct that was happening out there. And, it's not usual for DOJ to issue press releases, but based upon some of the stuff that was out in the media, you saw DOJ get a little bit more aggressive about issuing press releases and trying to make it clear to some of these folks that were getting out in terms of trying to promote the idea that Indian country was, some lawless environment to do whatever you want. And so this was helpful in terms of putting things in check, because in most tribal governments are, very, very disciplined and very committed in terms of, robustly regulating stuff, and you're going to have all kinds of varying perspectives on marijuana. One perspective we saw was in California, and you saw the feds come in and shut them down and remove their plants, and have seen some prosecutions that will likely follow from it. You did more recently see the Flannery-Santee Sioux. They were looking at doing kind of almost like a marijuana lounge resort situation where you could have up to an ounce. You could come in and you could buy marijuana from them. You could smoke it there. They were going to have a dance club, and in the state of South Dakota, it's still prohibited by the state, and they didn't do much of any consultation with the feds on it. And once they started to meet with the feds, shortly thereafter, they decided that they were going to take a step back and look at what they were doing. They're going to continue on with the idea of having their marijuana resort, but they destroyed their crop. They decided they were going to keep working on it. My guess is that DOJ said, well, we're not too keen on what you're doing. I think if you guys open up, we're probably going to come in and take some enforcement action. That's just a guess, but just a guess. In Washington, like I said before, early on, we started meeting with the Liquor Control Board. We started meeting with the governor's office and during outreach and talking to folks. We got the clarification from DOJ in terms of the Wilkinson memo saying tribes are going to be treated like states. And then the party of no continued to come in terms of, well, we don't think we have legislative authority to work with you. So our response to that was we ran a bill. We didn't run a bill, but the state ended up running a bill from some concerned folks because we could have, in Indian country, done a lot different system than what the state did. There's nothing that really requires us to work with the state other than it really makes a lot of sense as two sovereigns working together. We can have a consistent level in terms of quantities. We can work together in terms of making sure that packaging at our stores looks the same as the packaging at the state store. So we do the kind of same testing stuff. It really makes a whole lot of sense. And so we worked together. The House Bill 2000 was ultimately passed. The subject areas that it covered, allowed for, criminal and civil law enforcement in terms of us working together on that, regulations, medical and pharmaceutical research, taxation, immunities, dispute resolution, and we worked really hard on all of these things. It ultimately passed. It was the last bill of the regular session that year, House Bill 2000. I was sitting in the good old Capitol watching it pass. And then came the hard work of working with the Liquor Control Board in terms of negotiating what we called a compact. And we were the first compact in the country in terms of the Suquamish tribe negotiated the first marijuana compact in the country. You got a nice picture there, a nice couple pictures there, of us doing the signing with the board, and myself, Robin Saigo, who's our tribal council treasurer. Currently, there are 3 marijuana compacts between tribes and the state of Washington, 1 being the Suquamish tribe, 2 being Squaxin Island, 3 being Puyallup. Puyallup is more of a testing facility. They have a medical marijuana, not a medical marijuana, they have a cancer treatment facility on their reservation. And as part of that, they have a testing facility. And so they're working on doing testing primarily right now, and we'll see what they continue to do in the future. The Suquamish Compact allows for for production and processing and sale by the tribe and its enterprises, allows the tribe to buy from the state system as well as from other tribal outlets, other coal-compliant tribal outlets, ones that robustly regulate marijuana. We're all committed to that as a concept. Provides that all sales are exempt from state tax and includes refund mechanisms, provides for tribal tax parity in terms of we too charge that 37% marijuana tax and the retail sales tax. Provides for tribal enforcement with state cooperation. And then we went about, before we got the compact done, we had already started doing community meetings. So very early on, again, we had one of the stranger experiences I had was a tribal elder who is very, very vocal and passionate in terms of being a more traditional kind of person. And my offices are behind our hotel, and I was walking in shortly after I-502 passed, and she had the paper, and she's saying, "Ryan, we need to do this. We need to do this." I was really taken aback. And, and then we started the public comment stuff. We had meetings in the community, in our community house with, first time, 50 to 100 people in the community meeting talking about marijuana, the legalization, what kind of things they thought were appropriate. And we worked through all of that in terms of making changes to our tribal codes. In terms of the Controlled Substance Act, we created a code called the Commercial Marijuana Activity Code in terms of how we were going to license and operate it. So far, both Squaxin and Suquamish have treated it as a government entity in terms of the tribal government is running the business. We don't have any tribal members who are growing or selling marijuana under our codes. I mean, the state does in terms of allowing individuals to do it, but we don't do that at the tribe. So far, we changed in terms of, drugged driving, created a new entity in terms of that would run it. And so it's been, an interesting, brave new world to try to do this. It's something I never thought I would be in the position, and I'm sure Rick and everyone, never thought that the state would be there in terms of doing marijuana either. So it's interesting, and it's really rewarding in the way that I feel like we have done things the right way. Both the state and the tribe, in terms of working together, is the right way for us to approach this. We've had, in the past, more confrontational relationships associated with cigarettes, fuel, alcohol. This was really the first time that the tribe and the state got on the same page to start off early on and say, hey, it makes most sense if we work together on this, that we work in a collaborative manner so that we are ensuring that there's not diversion, that everything is tracked from seed to sale, whether that's on our reservations or in your state market. And we're also working in the way of how we're going to deal with medical marijuana, which we're not completely done with yet, but we're getting there. And I'm sure all the state folks, by the time we get done with that, will be tired of seeing me too. As another, example, I feel good about the fact if you look in Oregon, you're seeing, the Confederated Tribes of Warm Springs. They too are taking a similar approach. They're doing it in a little bit different model, but they have, been aggressive about working with the federal agencies. They've been aggressive about working with the state. They more recently launched a press event where they talked about how they're breaking ground on their $36,000 square foot production greenhouse, which they expect to have done by the end of the year, and they expect to have a couple stores that they're going to sell into and sell out of, and they're working with the state in a similar way in terms of taxes and on a compact, and so good for the state of Oregon and that tribe getting together and working cooperatively there. I still like to show how crazy it is for me to have us working on advertisements and everything else for marijuana, It's a brave new world. So what we know, the Wilkinson memo does not mean that cannabis and hemp cultivation are legal all throughout Indian country nationwide. No matter what you read, no matter what anybody says, federal law is still applicable in Indian country. It's still a Schedule I drug. State laws as to whether activity is criminal or civil in nature can be relevant to jurisdiction. And once the state really legalizes it, it really opens it up wholesale for the tribes to make a whole lot of decisions in terms of how they want to approach that topic. The close working relationship with DOJ is essential. I would encourage anybody who's working in this area to make sure you're consulting with your U.S. attorneys. Different tribes are going to have different perspectives and take different pathways. Similar to, Suquamish and Squaxin took a very similar pathway where you have Puyallup who is, doing it a little bit different and looking more in the area of medical marijuana at this point. And you're going to have tribes, more on the lines of not wanting to have anything to do with it. And, Yakima originally had been out in front of that. So there are tribes that are going to be combative in terms of not wanting to see legalization efforts. Compacts are not necessary but are useful in terms of a cooperative approach and, avoiding diversion. What we still need to know, what is the size of the market and how do tribes fit into the mix? Are there unintended consequences, or is the economic benefit worth those consequences? Will DOJ take the same approach under a new administration? We shall see. Well, at least Chris Christie isn't out there advocating that he's going to come shut everybody down. As an editorial note, one of the funny things in terms of our chairman likes to say is that the reason he liked the idea of compacting and working together was that if he was going to end up in jail, he wanted Jay Inslee sitting next to him. How will tribal and state laws continue to evolve? It's going to be interesting to see. You've got all kinds of interesting ideas that people want to do. What will local jurisdictions do more or less in the way of moratoriums statewide? How will tribes thinking evolve both at membership level and at the leadership level in the way of marijuana? So I thank you all for giving me the opportunity to come out and talk to you, as well as to see my good friends with the state, and I look forward to your questions. Thank you.
Thank you, Ryan. Just a quick reminder, so we have one more speaker, and then all four presenters are going to come up on stage, and we're going to do Q&A. If you have note cards for questions, please fill them out, and there will be staff going around the room and collecting those, and we'll try to get to as many questions as we can. Now, last but certainly not least, we have Alexis Harris, who is an associate professor of sociology at the University of Washington. Her research focuses on social stratification processes and racial ethnic disparities, particularly how contact with institutions like educational and criminal justice systems impact individuals' life chances. Some of her recent research has investigated the sentencing practice of monetary sanctions, including fines and fees, and she has a new book that's just about to come out, so I encourage her to give a book plug when she gets up here, since it'll be available, it sounds like, now or in the next couple weeks. And also in 2015, Professor Harris was appointed by the United States Attorney General to a 4-year appointment on the Office of Justice Program Science Advisory Board, and she recently presented at the White House at a convening on poverty. Dr. Harris will be talking about the changing cannabis market in Seattle and its impact on communities of color. Welcome, Alexis.
Thank you so much, and thank you for the invitation to participate. I just sort of say off the bat that I am an outlier for many reasons, being involved in this panel and the entire day, actually. I'm new to the study of cannabis, and I'll sort of sort of talk about sort of how I came to this study, just to give you a little bit of background. One thing I want to say is I'm probably one of the only sociologists in the room, except for maybe my graduate students that are in the room, and I've listed some of my students that are working on this project with me. But the way that I came to be interested in doing a study on the cannabis markets in Seattle is, so as Mark says, I study the criminal justice system and sentencing, and I have for the past several years. But early on in the 502 campaign, I had people from the campaign come to me and say, hey, would you write an op-ed? Would you come out and be supportive of legalization of cannabis? And I thought about it. They wanted me because I am a black woman, I'm from Seattle, I'm a mother of 2 small children, and I study the criminal justice system. And a lot of the rhetoric sort of used at the time, I'm sure you're well aware of this, around 502 was that if we legalize cannabis, it's going to in some ways address the racial disparities, disproportionate confinement of particularly African Americans in the criminal justice system, that this will sort of stop some of that flow into the criminal justice system that sort of started this mass incarceration and conviction since 1974. So that was sort of the rhetoric, and it got me thinking about sort of what is the role of race, racism, class, the criminal justice system in the legalization. So I did an op-ed, I thought about it, and after seeing it sort of play out and constantly change, I started having a lot of questions. So just to sort of outline, I'm going to talk a little bit about what we know, more about what we don't know. You'll see I have a lot more questions than any sort of answers, so please don't expect me to have any answers for you, but mostly questions, and talk a bit about our evolving research project that keeps changing constantly as the laws and the context change. But really, I'm also here to put on the table a sociological perspective, one that many of you may have not been thinking about but didn't find a space to put it on the table. Sort of how can we ask sociologically relevant questions about race and class around the cannabis legalization? So what we know, it's legal. To some extent, in certain parts of Washington, it's legal. We also know that a lot of money is being generated. So these are data from the website, which I actually think is a great website. I've learned a lot just sort of Googling and looking at the Washington State Liquor and Cannabis Board website. So a lot of money is being generated. And if we think about it, it's really interesting because, you know, how much of this money was being generated on the street, right, prior to legalization, and how much money is being generated now on the street, still in the unregulated market. We also know that the legal market is constantly changing, but we do know that there is still an unregulated and underground market. It's still out there, right? But what can we figure out? The Washington State alcohol, it's always a mouthful, I don't know how you remember to say it. Washington State Liquor and Cannabis Board sort of estimates it's about 75 to 80% of the entire market, but there's still little data to figure out what size is the underground market and who's engaged in it. It's predicted that over time, as more recreational dispensaries open, the underground sector will shrink. But we really have limited access to study that market. Who's engaged in that market? How much money are they making? How did the legalization impact that market? We also, and I think I've been a little bit liberal here in saying a great deal of research. I get it, there's not a great deal of research, but there is some research, at least on the medical side, impaired driving, pain management, things like that. But there's been no research on the sociological side. So what we don't know is who has access to enter legal markets and profits. Who are the owners, right? Who are making profits? We know that if you have a criminal background, you can't make a profit. So right here, it's really interesting on the rhetoric about legalization and the relationship to the criminal justice system is people essentially who have prior felony convictions, and generally people have more than one, right, can't enter the market legally. So they're automatically barred. And as Mr. Ramirez said, that we have people who are sitting in federal and in state prisons, right, for 20 plus years for doing what I can do today, go across the street and buy some weed, right? So they're still sitting in prison, and what does that mean, right? And we still have people who aren't even in prison or jail, but are on the streets with the felony convictions that bar them from accessing this market, which is really interesting sociologically. So when the board processes a criminal history check on an applicant, it uses a point system to determine if the person qualifies for a license. The board will not normally issue a marijuana license to an applicant who has accumulated 8 or more points as indicated in this table, and this is from the board's website. So all criminal history must be reported on the personal criminal history form regardless of applicability. Failure to disclose full criminal history will result in point accumulation. right? So effectively, if you have a criminal history, you're barred. We also know that it's a very detailed process, which rightly so, but it's a very detailed process. So people without wealth, right, access to banks, people with a criminal history, people without a great deal of business acumen cannot engage in getting a license. Again, so what does this mean for different types of communities? We also have questions about race and class differences in participation in the market. So this is a three-tiered market. I'm talking about a three-tiered market here. I get it. July 1, it's going to close, and we're sort of addressing that and constantly doing IRB modifications, adding new questions as the law is changing. But a lot of the questions that we have are who are the legal buyers and where do they buy? So do they move across neighborhoods? Do they go to one store, recreational store? What types of occupations are they in terms of race and class? Who are they with gender differences? Who are the underground buyers, and why don't they go to legal stores, right? So initial conversations with people who engage in the underground market, they talk a lot about stigma, right? But it's reverse stigma. It's stigma for going legal, right? That this historically has been a criminal justice system that has incarcerated people for engaging in this market. Why now would I go and pay taxes and pay the state? So there's interesting tensions between different types of communities, a different relationship from the criminal justice system and capitalism, essentially, which is really interesting. So broad questions about race that we're exploring. We know that there are persisting racial disparities in arrest even after legalization. I actually have a senior undergrad honor student who has great data and is actually also a student athlete who's doing amazing research and who's been looking at, over the past 15 years, changes in conviction rates for drugs. We can't take out marijuana with the data, but we can look at changes in drug conviction rates. And we see dramatic racial disparities, particularly in King County, for drug convictions. But over time, post-2012, we've seen a decrease and somewhat a convergence, still an overrepresentation of African Americans and Latinos in drug conviction rates, but at least it's decreasing, right, since we've been having conversations and the legalization of cannabis. But there's still racial differences. The war on drugs, as we know, have put millions of African Americans and Latinos and Native Americans and disproportionately South Pacific Islanders behind bars. Questions arise to how can we really address this? So broader policy questions around criminal justice system and how can we decrease that disproportionality and disparities. At the same time, really white men have been the face of legalization in terms of research, in terms of speaking on this issue. If you go through different websites of the different organizations, you really see that this is sort of the legalization is a part of the white community, right? We can do a sort of social construction analysis on what are the faces, right? And faces of color aren't really in that. So then questions are sort of asked about what does this mean? Is it about profit and profit for who? And then what happens to the black and brown faces that have those felony convictions and have served time for involvement. And as we know, there's also historical and ongoing systemic barriers preventing lower class blacks from accumulating wealth. And so if you don't have that wealth and access to the banking industry, right, how can you legally engage in this market? So these are some of the intersections with race which make the study of the cannabis markets extremely interesting in this context. Again, what we don't know, we also don't know who has access to enter legal markets. And, okay, sorry, that was repetitive. Talking about disparities by neighborhood. So part of the study, and I'll talk about this in just a sec, is doing surveys. Initially, I thought that we could drop off surveys at stores and customers would do it. Turn out customers just want to buy their marijuana and go home. But initially I was going to a lot of stores from Lake City all the way down to South Seattle and Renton and walking in and talking with people in the stores. And the stores are so different and so interesting and what they look like and what the neighborhoods smell like, actually. I mean, if you drive down Rainier in South Seattle, my kids know that that's the yucky, smelly street, right? And I haven't told them yet what that yucky smell is. But just sort of the quality of life question issues, or where are these stores concentrated in the city of Seattle, and how might they differ from North Seattle? We know I think you know, that we're extremely residentially segregated by race in this city. So what's the quality of life like? How does this impact the quality of life? Again, more questions than really any answers. And how can we reconcile the rhetoric used to pass 502 with current opposition to recreational stores in the Black community? What are people's perspectives towards recreational stores in the Black community? This is definitely not addressed in current work. I don't know if any of you are are Dre's fans, a local rapper in Seattle. But he recently, he's an African-American man, released a video, The Irony on 23rd and Union, just this week. But in April, there was actually a protest of Uncle Ike's, which is on 23rd and Union, historically sort of center of the African-American community. And there is a lot of irony here, right? Literally on this block, a black man was killed by SPD several years ago for drug involvement in drug possession, but hundreds and hundreds of black men have been arrested on this corner for selling drugs. They're still serving the conviction and still have the felony conviction, right? But now we have Uncle Ike's on this corner. So these raise really interesting sociological questions that we're exploring about tensions. And it's not that Dre's and people who are protesting, right? They talk about being cannabis consumers. So it's not anti-drug, but it's sort of what this represents in terms of gentrification, in terms of access to legal markets, these types of questions. So the specific research questions that we have is the now two-tiered cannabis market in Seattle stratified across racial and socioeconomic lines? Where physically are these different markets located in Seattle? Are they spread out evenly? Who owns them? We're looking at some of the business line, the records online to try and to see if we can determine race and gender, ethnicity, and get proxies for socioeconomic status. Who are the primary buyers and sellers in each of the 3 different markets? Oops, sorry. What are the demographics of the buyers? Where do they live? What are their buying habits? Have their habits changed since the legalization? The amount that they buy, and where they're buying them from? Who are the sellers across the different markets? How do they vary across the markets, and how and when did they engage in the market? Why did they select a certain market, either to be in the underground now or recreational? Have they now sort of sought out this expertise in the medical market? How much are they profiting? We can tell a lot of that from the website, but from the underground sellers, how much are they selling their cannabis for, and how much are they sort of bringing in? Trying to sort of also explore this notion of stigma and what it means to be engaged in either market or to buy from either market. What is the orientation towards the government in terms of trust, frustration, and anger? In terms of data, so what we're doing is one is just mapping out the locations, which is easy to do, and sort of look at the differences across the city of Seattle. Another is to do an interview sample of store personnel, which we're fielding right now, led by the great Michelle Cadogan's here, our great graduate students who are actually working with a team of undergraduate students as well to do the interviews. And we also have IRB permission to interview underground dealers, but the way that that's set up, I'll just tell you now because I'm sure you have questions about that, is that the contact to interview the underground dealer has to know the underground dealer. We can't just randomly say, hey, we want to interview. So this is why we're using undergrads, and I know the sample's going to be biased, and we were addressing issues like that. But basically, we have to have someone who knows an underground seller, and then they can reach out to them and interview them. That makes sense, and we can talk about that a little bit more. So we are interviewing some, and some are low level, just sort of selling enough to support their own habit. Others are selling across the state illegally. And we're also doing a survey, and we've moved now online survey to try and capture more people in terms of getting demographics and the types of markets that they participate in. We're doing descriptive and inferential statistics to examine the racial and socioeconomic differences. As soon as we get enough surveys, we can start doing that, and we're hustling to do that. And then in terms of methods, open coding of interviews and transcripts to identify common themes and concepts. The survey questions, and I'm a modification queen for the IRB, and so we're happy to add more questions if you'd like to add. Michelle's already working on one right now. But how their buying habits changed or not, how have people changed who they're buying from, right? With the legalization, did they stop going to their illegal seller, or did they go to a recreational store? Did they get a medical card? Why or why not? Perceptions about other markets in general, and how people understand 502, really. Sort of asking them, sort of what do they think is legal? How do they understand the changing laws? The hypotheses we have are just sort of thinking about sort of mapping what we know about the criminal justice practice and engagement in communities of color. Sort of hypothesize the underrepresentation of African Americans as managers, store owners, and sellers. We also have ideas about gender norms, and culture in cannabis market. underrepresentation of African Americans as buyers in the recreational sector. This may be wrong, but it's a hypothesis that we have that we want to explore. We're also thinking about the barriers to entry and the way that the legal and regulated market are likely higher barriers or more difficult hurdles for non-whites to engage in because of the mandatory financial investigation and licensing process, and then the prior contact with the criminal justice system and knowledge of the legal and criminal justice frameworks surrounding cannabis. So these are really sort of the issues. It's more, again, like I said, more questions. I think it's a really ripe area to study sociologically because it brings so many questions about culture, about gender norms, about race, about the criminal justice system, all to get gentrification, economic markets and labor. As Mark said, I can do my book plug now, I study the sentencing of fines and fees to defendants, people convicted of felonies, misdemeanors, district court, federal. So everyone gets a certain amount of financial obligations when they're sentenced. So I really look at the revenue that the state generates as a result of conviction and involvement in the criminal justice system. To me, the study of the cannabis market is very similar, right? The state has legalized a certain realm in society and is generating money and also allowing other people to profit off of that, as we do with the private sector in terms of collection. So to me, they're very parallel processes. In one, disproportionately poor people and people of color are seen as the revenue source, and then the other, in terms of who's allowed to profit, it's a very different, I hypothesize, market. So to me, it's very interesting from an economic, sociological perspective to study sort of the similarities in actually what the state allows us to do, and who benefits and who, of course, doesn't benefit any further. So thank you. I'm open to questions and ideas. Appreciate your attention.
Thank you, Alexis. I would ask that our 4 presenters come up on stage, and we have microphones available for you. We already have a nice pile of questions, but we have a fair amount of time, so hopefully we can get through all of these or most of these questions. And I would also encourage the panelists, if you have questions for one another, to go ahead and raise those as this panel goes forward. So one of the first questions, there's a couple of, I think, goes to you, Chris, and they're interested in what was the process for determining what is a high THC product and what type of considerations were used in coming up with the range levels for the high THC, but also the high CBD.
Sure. See, is this on? Okay, good. So I will admit fully, I am not the lead expert at the department on the product rules, but I think the primary things that were involved when looking at, how to classify these products, obviously looking at what was already available through the recreational market, obviously trying to find that right public health balance between, allowing patients to meet their medical needs, but also wanting to make sure that products weren't going to have doses in them that, could be especially dangerous to youth and kids that might be in these homes. So, for example, you'll notice in our high THC products, you're not allowed to have edibles, for example. And with the high CBD products, I think the main thing was really looking at, what kind of ratios really, based on the limited research we have available, would indicate to us that you have very little chance of becoming high from those products, because that was really the gist with the high CBD was, ones that could be, again, sales tax free to any adult consumer. And so those, I think, were the primary bents at a very high level, but I will admit I'm not the primary expert, and if you'd like more on that, please send me an email and I can put you in touch with Christy Weeks, who is the primary person who focused on our product rule.
Great. Can I ask a question? Sure.
I'm going to jump in because I was fascinated by all the presentations, but Alexis, having grown up a Hispanic in the Yakima Valley, I'm going to tell you anecdotally, when we bought pot, we bought it from white guys. We didn't buy it from Mexicans. So there's a part of that research that I think to myself, what do we know about it before legalization? In other words, I suspect it is white men that are going to be in most of the businesses, whether they're producer, processors, or retailers. But we ask those same questions when we get questions with respect to the group in front of us today. It's like things are getting worse. Well, believe it or not, when medical marijuana, the initiative passed in '98, things began to change because of the therapeutic values of cannabis, it became easier for folks to get a hold of marijuana and for me to get a card, whether I truly was a patient or not. But I think we always have to back up to look, I hope, Alexis, at what do we know before we look at the impact of legalization?
What we know speaks exactly to what you just said, is that we know that whites used and, to the extent sold, Catherine Beckett has done research on this with Chris Nierop, to the same degree that African Americans and Latinos have used and sold. However, African Americans and Latinos were disproportionately incarcerated and convicted and carry the felony stigma. And so if we think through history, what we know before and what we know now is that, yes, things have equalized in some degree with legalization, but communities of colors can't legally engage in the market because of that disproportionate arrest and incarceration. I think that's what we know right now.
Okay, great. Rick, this is a question for you. There were a couple on what's going on with pesticide rules at this point, and I know there's been some sort of emergency rulemaking taking place, so could you maybe just kind of describe what the issue that those rules are needed for and kind of what the current state of things are?
Sure. So one thing that was said earlier with the guest speaker that I keep hearing over and over again is the policy is ahead of the research, and maybe pesticides is a good example of that. Well, because of the challenge of it being a Schedule I controlled substance, we don't have the help of the APA. We don't have the help of the federal agencies that regulate these kind of chemicals, those that can be used as far as pesticides, those that cannot. For instance, we had a no tolerance policy with respect to pesticide residues until Wednesday, when we basically took, through emergency rules, the Oregon regulations with respect to action levels, what kind of residuals, for a better, maybe 100 parts per million with respect to a chemical that's either allowed or not allowed. So I'm sharing with you that we have a quality assurance group that started meeting 3 weeks ago. By the end of July, we hope to have a standard there. We're using the Oregon regulations because they're a beginning point. But even in the work group that's been meeting, we think there need to be changes to what we even adopted on Wednesday. But that's concerning to us. And I think it's even more concerning when we hear the concerns that the medical dispensaries had, that in fact there was no testing going on. So regardless of what you hear, for the most part, not always, there were very few dispensaries that were using labs to test for pesticides or to test for fungus, mold. So patients have been smoking marijuana, I would suggest for a while, that is not safe. And so I think as we move toward legalization, it's going to take time, but hopefully we will have all cannabis in Washington with the reconciliation. We're looking at working with the Department of Agriculture to have them do random samples of all growers and processors for pesticides, and we hope to have that in place in the next 3 to 6 months.
Okay. Thank you. And a question for you. Are the tribes doing anything kind of on the prevention and treatment front in terms of funding for other groups or trying to coordinate with the state as the new marketplaces emerge there?
I would say, the tribe is in a situation of, we opened our store in December and are in the process of really figuring out what the tribe's going to utilize some of the money for. It can use it for essential governmental services. The tribe's committed to the prevention model, and right now they're still doing their homework in terms of what they might do. One of the ideas is funding an Oxford House for the tribe in terms of inpatient care. There's a lot of ideas in regards to what we're going to do in the way of the utilization of some of the monies. But ultimately, I'm sure you will see the tribe utilizing a fair share of it for prevention and lots of different things associated with the, diversion and treatment and all kinds of stuff. But it's to piggyback on what Rick said, a lot of this is very, very, very new, and a lot of it you're creating out of whole cloth and creating things that nobody's ever done before. So you're in a position of having to take some time and give people an opportunity to work through everything. We're working through the medical stuff with Chris over here in terms of some of that stuff, in terms of how our systems might work together. And we are looking and exploring opportunities in terms of what we are going to do in the way of prevention and the like. But so far, we haven't picked the exact model. We're just, slowly working through it.
And credit to Rion and the work of his tribe and others, because nowhere in the country are there compacts between two sovereign nations. We're the first. It's not the first time we've been the first with respect to the state of Washington and working with tribes, but as Rion knows, this was difficult. I think for us, we were naive to the fact that, well, wait a minute, because we were asked initially when legalization occurred from tribes, well, what do you think? And it's like, well, aren't you on federal land? And didn't the U.S. attorney say that nothing can be, you can't have it in a federal building, federal employees, or on federal land? So we were kind of naive to that to begin with, but because of the efforts of Rion and others, we have two compacts, another that we're going to sign any day with the Puyallups, one that we're working with the Muckleshoots, and two other tribes. So I think to Rion's presentation, that effort makes sense to work collaboratively together to have systems that are similar. And I think that in those negotiations, because this is not the first time we've worked with the tribes, we have memorandums of agreement for alcohol sales with the tribes. They do not have to receive a license of the state. As sovereign nations, we have an agreement between the nations for how the alcohol service will occur and enforcement, whether that's cooperatively or not. The tribes have enforcement arms, as you know. So I just want to give credit to Rion for moving forward and getting that legislation passed, because to be honest with you, we were set back at first and concerned about, hey, Rion, we can't do this. So
yeah, we had lots of interesting discussions, and it's nice that we're all here collegial now, and we worked through a lot of good stuff, and I got to give a lot of credit to Rig, to the LCB staff, to the board in particular, in terms of Ruth Ann, Jane, and Russ, and in terms of what we did do. I mean, they were very committed to the integrated system and worked really hard to make all of that happen. So I mean, it really is a joint effort, and I think as citizens of the state of Washington, we should all be very proud of how the two governments have worked together.
Alexis, this question is for you, but I think all the panelists may have thoughts on it. But so for your research, are you going to look at the impact of city, state, county regulations and ordinances on kind of the groups that you identified, particularly licensees of color, youth, and kind of how this network of regulations and state laws kind of influence the marketplaces? But I'd also be curious from the other panelists to see, how is your work affected by having, not consistent rules across the entire state?
Right. I mean, that's definitely a great question and a great point. Right now, we're at the baby stages, right? So pilot stage, trying to figure out the lay of the land within just Seattle. Given now sort of the King County Council and sort of what they've done in South King County is really interesting to think about who has the right to do business. So we'll be asking questions about that. I foresee later on, we've talked about maybe if we can get some grant money to branch out into other parts of the state and maybe see what's happening east of the mountains, and looking at sort of the overlap of policy and how that matters differently for different people in different cities and counties. So yes, those are questions, down the road questions. Right now, we're just trying to figure out what's going on in Seattle, if we can map that out.
I guess from the Department of Health's perspective, I think the most difficult challenge with the local moratoriums and bans is obviously access for patients, from our perspective. Having areas of the state where we're not sure if patients are going to have products available to meet their medical needs because there isn't the ability for the medically endorsed retail stores.
And then for us, I mean, I was talking to Chris about this earlier, because we're working on the medical stuff right now, but even with the legalizations to begin with, we have a lot of community discussion, a lot of hearings, a lot of review, similar to what other governments do in terms of the way we're changing the laws, and we get a lot of community comments that may agree, disagree, not be happy with some of the stuff that we're doing in terms of they want to do it differently. And so for us, it's really a unique experience because we have a lot more flexibility in terms of what we might or might not want to do. By and large, the tribe has been, I would say, if anything, more conservative than the state, especially around some of the youth access kind of ideas. I mean, that's something that the tribe's been very, very committed to in the way of, on the medical side right now in terms of our preliminary draft of what we're going out for community comment within our community is not allowing youth access at all for anybody under the age of 18. Whether the general membership likes that and whether the council ultimately does it that way, we'll see. I mean, but there's a lot of unique and interesting processes around this and competing views and competing interests between the state, between our community, between the feds. So it's a brave new world for us.
Well, I think it's problematic. Before we began issuing licenses a couple of years ago, we actually asked the Attorney General to give us a formal opinion. Does the local jurisdictions, cities and counties, have the authority to impose bans and moratorias, and are we to issue those licenses in those local jurisdictions that have imposed them? Unfortunately, the Attorney General came back with two thoughts that didn't help. One was, yes, local jurisdictions have the right to impose bans and moratorias because there's nothing in the initiative that suggests otherwise. And then Liquor and Cannabis Board, you must issue licenses because there's nothing in the initiative that says you have to consider the ban or moratoria. So you can imagine that. So we are issuing licenses in communities that have bans and moratorias, and they're pretty outraged by it. I was in Spokane last week. There was actually a Senate committee hearing looking at not allowing retail locations within an alcohol impact area. But I'm sharing with you, that's kind of the dysfunction that's there, where the locals look at us and the state saying, what are you doing? Why are you issuing licenses in disrespect of the fact that we have a right to impose the bans or moratorias? And believe it or not, if we didn't, the applicant could then take us to an administrative hearing and probably win because that was not part of the requirements to get a license. So I think that's a bit dysfunctional, and I think we continue to struggle with that. We have issues in Kent, in Auburn, in Spokane, in Seattle. I think one of the interesting things about the unregulated medical marketplace over the last 5 and 10 years is the concentration of those dispensaries where. And I'm thinking of Rainier specifically. And that's the concern, and I think the need to look at the research about where is the legal system, where are those growers, processors, and retailers? Are they going to take the same strategy or the same reality that we saw with alcohol and liquor stores? And in other places that don't have controlled states, like Washington, go to California and see where all the liquor stores are located, because it's demographically motivated. But I'll stop there. Thank you.
Had a question about kind of the earmarked tax revenue and the budgets and kind of what that process was. And I'd like to add on to that there's a provision in I-502 that says that periodically LCB and OFM are supposed to review tax rates and try to set kind of a price sweet point that is going to be affordable enough to undercut the black market, but high enough to discourage youth. So I'm just curious as to whether or not that process is underway, since I think it does tie into kind of this overall budget question, and we've already seen that, I-502's original earmarks have already been changed a little bit. So could you maybe comment on that?
Well, I think we've stayed away from that a little bit because obviously the first 2 years you needed a 2/3 vote to amend anything in the initiative, and we really don't know what the proper excise tax is. It was 25% at all 3 tiers, and then last year legislation was passed, I think House Bill 2136, to move it toward retail at a 30% a 37% excise tax. If I was part of that industry, I would think it's too high. But let me share the reality, and this is another discussion with Allison Holcomb. If you know anything about our state, we don't have an income tax. Oregon does. Our tax base is very different than other states. We actually tax high with respect to what I'll call sin taxes. Alcohol, we have the highest spirit taxes in the country. Cigarettes, we have the highest cigarette tax, I believe, in the country. And this flows with cannabis. I think we have the highest excise taxes for cannabis in the country. But if you go back to talk to the proponents, what were they offering to do by legalization? Create a revenue stream for state government and for citizens in the state. So I think we need a little bit more time. I can tell you right now, it's higher than anywhere in the country. I think the excise tax in Oregon is 20 or 25%. But I think that's something that we'll do. There have been efforts by the industry to go to the legislature to lower that tax, and there's some support for that. But what are we going through right now? We've got a $2 or $3 billion hole in the budget that they've got to fund McCleary, a lawsuit that's still pending with the states. I don't see the taxes for cannabis or for anything going down.
Chris, this is for you, I think, and it's kind of twofold. So as Department of Health is, now having to work with the 502 marketplace and merge these two systems, the first part of the question is, have you been working with the I-502 industry in creating kind of those rules? And the second is, are there regulations in place to kind of include other healthcare services within the stores that have the medical endorsements, right? So hypothetically, could a retail store have, treatment provider on site or some sort of health resource person to kind of provide additional information to the customers?
Yeah, so as far as involving the industry, we certainly had, tried to keep a very open process. We've had a listserv for medical marijuana for a long time. We've also obviously been working very closely and collaboratively with the Liquor and Cannabis Board. For the database, we have a medical advisory work group, which actually does include 2 stores. One that started with a 502 license and one that is a dispensary converting over to being a licensed store. And, we really have tried to keep them involved and informed of all of our rulemaking processes, especially the ones that affect them the most, which would be the consultant rules and the database rules. The secondary question, can you repeat that one again? I apologize. I just want to make sure I understand it correctly.
I think the question is, for these new 502 stores that have the medical endorsements, right? Would it be possible for them to kind of have additional kind of healthcare resources available for patients that are using them?
My understanding is no. Okay? I mean, again, I think they're restricted, Rick, correct me if I'm wrong, to medical, the products and the paraphernalia, and that is it. And again, you also heard as part of my report, the idea of specialty clinics is currently not allowed, where you could both authorize and dispense from the same location. So I don't think there's any way legally to allow for that, even if the Department of Health thought there were other services it would make sense to have there.
Okay. Ryan, this one's for you. So, and correct me if I'm wrong, if this question isn't quite totally accurate, but so if the Squamish Tribe represent and owns, it's kind of more of a government-controlled model, right, versus kind of a regulation private model. Do you see any kind of pros and cons between those two?
Do I see any kind of pros and cons? Well, on the tribe side, the tribe looked at it in terms of what it felt was best for its community. And one of the comments that, is kind of funny, but very true in terms of our community, one of our council members, one of the hearings that we had some of the general membership advocating for the idea of personal, for them to be able to grow and sell on the reservation and what have you. And he said, he looked at his membership and said, why don't you give us a chance first to see if we go to jail before we put you at risk? That's funny, but it's true. This isn't something, it's a Schedule I drug. We are all part of a grand experiment. There are people in other states, other jurisdictions doing life for what we're doing here. So we need to be smart, we need to be measured, and we need to be responsible. And so It's not my policy decision, but our tribal council's policy decision was to take a conservative approach and to be in a position of looking at it as what they thought was best for their community in terms of making that grand leap. I mean, we are one of 2 tribes in the entire United States, quote unquote, selling marijuana legally. We're one of 2. And so it's a very, very formative stage of things. And so far, the tribe has taken the approach that it wants to be as protective and measured as it can. Ultimately, the council and the tribal leaders will make a decision in regards to next steps, next iterations. But the model that they have gone with is a model to try to be as protective for their community as they can. I mean, it allows for greater controls in terms of what goes on in the store, allows for greater controls in regards to, testing, and just ensures that we are able to, at the beginning stages, make all those decisions and do everything in as thoughtful and measured a manner as we could. So, I mean, we in Indian country have, often had to suffer the brunt of bad decisions that people externally have made, and our tribal leadership decided that it was time for them to take control of it and for them to shepherd it through and ultimately look at it at a later point in regards to what else they might do. But for them, they felt it was the right and responsible thing to do.
Yeah, I'll tell you personally, I think the government model is the best model for the tribe or for the state. I've been asked, I mean, it's not going to happen here because the initiative has passed and we have the private sector do it. But for those who are concerned about prevention, treatment, health, I believe that the best model is one where the government takes control of the manufacturing, distribution, and possibly allows retail outlets. It's basically the liquor control model. If you take the 17 control states and you compare it to the 30 open states and you look at the per capita consumption of alcohol, it's 18 to 20% lower in the control states where there are restrictions in advertising, there's limitations with respect to the number of outlets. All of the goals that we had when we had the system ourselves was there to drive down consumption and youth access, and it did.
Great. Alexis, this one's for you. What, in your view, could be done social policy-wise to sort of make the I-502 market a bit more egalitarian when it comes to communities of color or socially, economically lower communities?
I think it would have to go hand in hand with the sort of changes within the criminal justice policy, that we'd have to revisit criminal convictions. Sentences, definitely, I don't think people should be, so sort of related to both, serving time for something that's legal now. But I wonder why we have the felony restriction on people who can engage in the market legally. I get that we don't want to have sort of a criminal element to it, and maybe the assumption is those people with felony convictions for prior drug sales might bring in a criminal element. But if it's legalized now, then there shouldn't be this stigma attached to people who had convictions, who were engaged in particularly marijuana convictions in the past. So I question that. Like, why is that limitation there? I think maybe, and I don't know, maybe you're doing this, and I haven't studied this yet, but doing educational forums in communities of color and helping entrepreneurs access the market in a legal route. But thinking about sort of ways in which we can take affirmative action in cannabis industry to help diversify it.
Yeah, the felony conviction has to have been within the last 10 years. Mm-hmm. So if it was before that, so we do have folks who have had felony convictions who hold licenses. And in fact, there was a story just a month ago in Issaquah where one of the retailers actually 13 years ago committed murder and was able to hold a license. So I don't know how I feel about that, to be totally honest with you, but there is a way that people with felony convictions can have access to the marketplace.
Chris, a couple more questions for you just about the changes that are coming with medical marijuana. So a couple, hopefully concrete ones, and then I have one additional. So for the registration cards, so those are going to be printed at the stores, and are they good for at any 502 store that has the medical endorsement? One Why don't you just start with that, then I'll ask the next one.
Sure. So, yeah, the recognition cards are, again, created, printed, laminated at a medically endorsed retail store, and then they can be used to make purchases at any other medically endorsed retail store.
Okay, and then so for the consultants, the medical marijuana consultant positions, is that a role that's going to be sort of employed or supported by the state, or is it the retail establishments that sort of have to have that staffing?
Yeah, so again, under LCB rule, each medically endorsed store has to have on staff at least one consultant. And then under our database rules, consultants are the only ones who can enter someone into the database. But the certificate or the license does come from the Department of Health. So they apply for a credential with the Department of Health, but then it is used exclusively at a medically endorsed store.
Okay, and I guess my question is, I think there's going to be a lot of nuts and bolts questions. Where's kind of the best resource to really kind of get answers to these kind of FAQs?
Again, I think our website is kept up to date pretty well. I'm not saying it's perfect, but we are consistently trying to make sure it's updated. And right now, like I said, it has a lot of good information about all these, the training programs for the consultant application, the recognition cards, the authorization forms, all the questions that we've been getting. We continually update and try to make that information available there. That would be it. And again, the short URL is just doh.wa.gov/medical marijuana.
Okay, great.
Well, and I would say one of the things I think is interesting is if you look at how many retail stores have applied to become to have the certification. I mean, nearly every store is going to have the certification. I think right now you've got 230 some odd that have already applied for the certification. So
8 out of 10 that were original I-502 stores, and then 100% among those dispensaries who are qualified. Remember, there was a priority system created that you had to have been a dispensary before January 1st of 2013 to even qualify as the new licenses, the 222. I'm not aware of any that haven't asked for the endorsement. And again, 8 out of 10 originally, so it'll be a little bit more than 80%.
Great. A couple of different questions, again, going back to the new tribal marketplaces that are opening up. Are those, in terms of regulations, are they pretty similar to the I-502 regulations? And an example of that would be like public consumption, driving, or are they similar or different?
Yep. I mean, yes, public consumption, it's prohibited under the tribal code. Drug driving is prohibited under the tribal code, uses the same standards. One of the areas that, was an interesting spot in terms of how we were going to deal with drug testing in terms of pre-employment and random drug testing. We do a lot of we have over 1,000 employees on the business side in terms of how we deal with that. So that was the first iteration of things in terms of what do you do when you are in a position of historically always testing for marijuana and you're going to open up a retail store. There was a number of folks on the board and on council that thought it was hypocritical for us to be in a position of having a store and then not allowing people access to having a job because they test positive for marijuana. So we eliminated marijuana from our testing schedule for pre-employment and for random, except for if you fall into a driver category in terms of if you drive shuttles and stuff like that, we still test you for it. Additionally, if you're in a position of where you get in an accident or near accident or for cause, we test you too for marijuana in terms of the screening there, and you can't test higher than 50 nanograms per milliliter of urine. And that was after consultation with our medical review officer. That wasn't a number we picked out of the air. It was through consultation with him, and he suggested it. Whether it ends up, so far it hasn't been too big of an issue. We've had 2 incidences in the last year and a half in terms of folks that have hit hotter than that 50 nanograms per milliliter of urine. But yeah, so by and large, we are consistent with the state. Like I said, we're a little bit more conservative on the youth access stuff, at least currently. We don't want to see youth have access to marijuana, and ultimately, we'll be very, very similar to the state.
Great. Another question kind of about the merger of the medical market. In terms of public education, are there going to be new campaigns that are going to be focused kind of on the difference between recreational and medical marijuana uses? Since it's probably already very confusing for the public, and I assume that confusion will exist as these two markets kind of come together.
Yeah, to be honest, the prevention division in our agency is the one who houses all of our prevention work around marijuana. And it is a little bit of an interesting thing from a public health perspective, because in one division, we're helping implement medical marijuana, but then in another division, as you saw from Rick's slides, we have, a whole prevention campaign. And so, to be honest with you, I'm not sure what their plans are around that. I know Kathy Tedrick, again, our communications person on our side, does meet and have conversations with, obviously, the other side of our agency to talk about, where can we align our work and make sure that we're on the same page, because it does get challenging, especially, I think, in the area where you have a medical patient who is underage, because that really is, I think, the most challenging dichotomy there. When you're like, okay, we're trying to prevent youth access, but you have a qualifying condition, and you do use medical marijuana appropriately to treat that condition, it's going to be some challenging work for us.
Well, I think it'll also be interesting to see how the standardization of the written authorization impacts the amount of medical cards and the like. It'll be interesting to see also in terms of youth, how the higher standards associated with the written authorizations for the youth impact things. So there's also a lot of unknowns in that regard.
Okay, we're just about out of time for lunch, but I wanted to end with all of you just having the opportunity to maybe offer prediction for the group in the next legislative session that's coming up. What do you see as kind of being a really big challenge that are facing all these different parts of these new marketplaces, with the one caveat that you can't just say because it's illegal federally?
I guess my first thing that popped in my head is some of the bills that we saw last session that might come back. I think some of the more interesting ones were, home delivery, the bill that it was only for Seattle, the way it was written, which was kind of interesting. It didn't pass. And then also, I think the other one that stood out to us was, the marijuana lounges and clubs. That creates a lot of different public health considerations when you try to think through that issue and, what should or could be allowed, if anything. Those are, I think, the two things that I think may come back next session and would be definitely on the Department of Health's list of bills to watch for and to try to work through.
Ours isn't necessarily in terms of the state level. I would say the most interesting stuff on our side is going to be how we ultimately end up doing the integration work associated with the medical marijuana area, also in the way of working through some of the issues associated with the producing and processing, in terms of we will in short order be in a position where we're processing and selling into the 502 system through the BioTrack system, and working with all of that in terms of we have the ability to do it under our own system if we choose to do it under our own system in terms of tracking from seed to sale. But so far it's been most effective and most efficient to just be part of the BioTrack system and work within that environment. And so far, we're working through some of the bugs and some of the other stuff associated with doing that processing and selling into the 502 system. So once that starts getting moving, that's going to be something that's going to be interesting to watch and see how it progresses and how it grows.
I have no idea, but I can say what I'd like to see. I'd like to see the expungement of convictions for possessions of marijuana.
I think for the first time, I'm not really too concerned about what's going on in the state of Washington. I think we have a pretty constricted and restricted system that we've created compared to the other states. I'm interested in the letter that Patty Murray signed recently asking the DEA to schedule down along with other members of Congress. I think it's interesting to see what's going to happen nationally with this effort. Don't forget that California is the 7th largest economy in the world. If it legalizes, it will have a ripple effect on the rest of the country. 90% of the marijuana that's grown in California is exported out of the state. It's the #1 cash crop in California and has been for 20 years. So I think you're going to see on the Northeast and on the West continued efforts to legalize, and then watching to see what the feds do. Once the feds schedule down or begin to make changes, the reason why it matters to us is then the banking issues can go away. And that's a real problem right now. How do you keep it out of the hands of criminals or people are walking around with bags of cash? So for us, I think more watching what's going on outside the state is probably more important than what's happening inside right now.
If I can tag on to that, one thing that we've considered at the Department of Health is if the federal government does reschedule it, but schedules it into one of the schedules 2 through 5, which is still only for prescription use, then the system we've set up in the state, it doesn't work because those drugs have to be prescribed, not authorized, and they have to be dispensed out of a pharmacy, not out of a medically endorsed retail store. So that's just something else that I think is a real interesting wrinkle to the whole mix.
Okay. So I'd like to thank our panel